Good morning, everyone. Welcome to the second day of the May 2021 Advisory Committee on Heritable Disorders in Newborns and Children meeting. I'm Dr. Cynthia Powell, Chair of the committee. We'll begin with the roll call. Kamala Mistry.
Here.
May Baker.
Here.
Jeff Brosko.
Present.
Kyle Brothers.
Here.
Jane DeLuca.
Here.
Carla Cuthbert.
Here.
Kelly Kelm.
Here.
And for Hersa today, Joan Scott.
Here.
Sean McCandless. Melissa Parisi.
Here.
And I'm here, Cynthia Powell. Anna Marie Saranen.
All right, here.
And Scott Schoen.
Here.
And for our organizational representatives, Robert Ostrander. Deborah Friedenberg. Maximilian Mjunke.
I'm here.
Stephen Ralston. Jed Miller.
Here.
Susan Tanksley. Chris Kuss.
Here.
Shakira Henderson.
Here, hope you guys can hear me today.
Yes, thank you.
Awesome, thank you.
Jennifer Kwan.
Here.
Jacob Hogue.
Here.
Natasha Bonham.
Here.
Sean Dolan.
Here.
Kate Walsh Foxley.
Here.
Georgianne Arnold.
Here.
Is there anyone whose name I called who wasn't able to respond but is present? Okay, thank you. I'll next turn it over to Mia. Oh, I'm sorry. One thing before we start. Okay. Today we'll begin with an overview of the National Survey of Children's Health data. We have one individual registered to give public comment on updates to the committee's evidence review process. After the public comment period, we'll break until 11:40 Eastern Time. For our final session of the meeting, the committee will hear a panel presentation on workforce issues related to short and long-term follow-up. I'll now turn it over to our designated federal official, Mia Morrison, to provide guidance for participation on the webinar.
Thank you, Dr. Powell. For members of the public, audio will come through your speakers, so make sure that your computer speakers are turned on. If you can't access audio through your computer, you may dial into the meeting using the telephone number in the email with your Zoom link. This meeting will not have an attendee chat feature, but we do have the public comment period scheduled later today. Committee members and organizational representatives, audio will also come through your speakers and you will be able to speak using your computer microphone. If you cannot access the audio microphone through your computer, you may need to dial into the meeting using the telephone number in the email with your user-specific Zoom link. Please remember to speak clearly, state your first and last name to ensure proper recording for the committee transcript and minutes. The chair will call on committee members first and then organizational representatives. In order to better facilitate the discussion, committee members and organizational representatives should use the raise hand feature when you would like to make comments or ask questions. Simply click on the participant icon and choose raise hand. Please note that depending on your device or operating system, the raise hand feature may be in a different location. To troubleshoot, please consult the webinar instructions page in your briefing book. Next slide, please. To enable closed captioning, please select the closed captioning icon from the Zoom taskbar. From the menu that appears, select Show Subtitles. And I will now turn it back over to Dr. Powell.
Thank you, Mia. Today, I'm very pleased to welcome Dr. Julie Donnie, and Dr. Reem Gandour from Hersa's Maternal and Child Health Bureau, Office of Epidemiology and Research, who will provide an overview of the National Survey of Children's Health. The National Survey of Children's Health provides rich data on multiple intersecting aspects of children's lives, including physical and mental health, access to quality health care, and the child's family, neighborhood, school, and social context. The National Survey of Children's Health is funded and directed by the Health Resources and Services Administration Maternal and Child Health Bureau. This is an opportunity for the committee to become familiar with the available national survey data, especially data on genetic conditions, and how they go about collecting the data, and learn about potential future innovations and new approaches for the survey. I'll now introduce both of our speakers. Dr. Gandour is the director of the Division of Epidemiology within the Hersa Maternal and Child Health Bureau's Office of Epidemiology and Research. Her individual portfolio includes conducting original research on a variety of maternal and child health issues, with a special focus on children's mental health, early learning, and children with special health care needs. She has been recognized by the Coalition for Excellence in Maternal Child Health Epidemiology twice, winning the Maternal and Child Health Young Professional Achievement Award in 2011, followed by the Effective Practice Award in 2020. And in 2016, she received the Maternal Child Health Bureau Directors Award at the Title V Federal State Partnership Meeting. Dr. Donnie is part of the National Survey of Children's Health team, where she conducts original research on child and family health. Examples of her previous research include promoting flourishing during early childhood, mental health of teen parents and their children, parenting practices of Latino immigrant parents of adolescents, and child abuse prevention. Dr. Donnie holds a PhD from the University of Maryland School of Public Health and an MPH from the University of Montana's School of Public and Community Health Sciences. I will now turn it over to Dr. Gandour.
Thank you so much, Dr. Powell, and thanks to all of you for allowing us to take a little bit of time this morning to talk about the National Survey. Let me just do a quick check right now. Can everybody hear me all right?
Yes.
Okay, fantastic. So today, Julie and I are going to do sort of a high-level picture of the survey just to familiarize you with the survey as a resource. And we will be providing some key estimates just to also give you a snapshot of some of the data that are available to you. And then ultimately, we're going to wrap up with just giving you a sense of where the survey is going. We're happy to keep this informal. So if you have questions, please feel free to use the raise hand function, and I'll do my best to sort of keep an eye on that as well as we go. Next slide, please. So our goal today is really fourfold. I will provide an overview of the survey and just touch on a few key differences. I think many people know that the survey was redesigned dramatically in 2016, but there's still a fair number of folks who are used to working with the previous National Survey of Children with Special Healthcare Needs. So I'll just make sure that we're all clear about kind of where the survey is now and how it's administered. Julie is going to present some key estimates using a combined data file from our 2018-2019 survey. I will talk about how you get to the data if you want to start using it yourself, and then we'll give you a sneak peek into sort of what's coming in the next year or two with the survey. Next slide. And next slide. Thank you. So just as was briefly mentioned, the National Survey of Children's Health is sponsored. It's funded and directed by Hersa's Maternal and Child Health Bureau, but I think it's really important to note that we have co-sponsorships from other parts of the federal government. particularly CDC. We work quite closely with a couple of different divisions there, as well as USDA. We are now conducted by the US Census Bureau. So for folks who were familiar with our previous surveys, we used to be conducted as a telephone survey through the National Center for Health Statistics. This is now an address-based survey that's conducted using the master address file from the US Census Bureau. One of the other ways the survey is dramatically different now is that it is an annual survey. So it remains cross-sectional, but it is an address-based survey, and about 75% of our data are collected via the web, with the remainder being collected via paper and pencil questionnaires. Although the administration and the mode of the survey is dramatically different than what we did in the past, the survey remains true to our overall goal, and that is to collect information on the health and well-being of children from 0 to 17, as well as the sort of spectrum of community, family, healthcare related factors that can influence children's health. And we still provide national and state level estimates. So that remains important from a policy perspective. What we do is the survey is in the field for approximately 9 months. We go from June to roughly January, and then we release the data the following October. So for those of you used to federal data collection, this is almost lightning speed, not quite real time, but pretty darn close. And so you can usually look for the latest data release sometime the first Monday in October. Next slide. We cover 8 broad content areas universally across for all age groups. We do have separate surveys, slightly different for 0 to 5-year-olds, 6 to 11-year-olds, and 12 to 17-year-olds. But what's presented here is really the core content that runs across the survey. Where I think this committee may be most interested is in general health, where we have our our condition list, which includes blood disorders as well as other genetic conditions. And it also gets at activity limitations and some of the functional limitations that may be relevant to this, to some of the work that you're doing. And then in addition to infant health, preterm birth, low birth weight, for the 0 to 5-year-olds, we cover infant feeding and infant sleep position. We have a range of content that gets at both the access to and utilization of healthcare services, particularly specialists, in addition to the normal preventive care, as well as the quality of the care that is received, and specifically looking at the receipt of care in a medical home. We go deeper than any other survey with regard to health insurance. So we're looking at not just the status and the type, so are you insured and what's the source of that coverage, but we do ask parents a series of questions about adequacy. So folks are able to report on whether or not their child's needs are actually being met. And then we have a range of items that were brought over from our previous National Survey of Children with Special Healthcare Needs that focus on the impacts within a family of caring for a child with a special healthcare need, be that a genetic condition or some other condition. And then of course we have content that's related to family and neighborhood factors. For very young children, we've also now included a range of content related to healthy and ready to learn, which is specifically sort of school readiness in the simplest terms. And then for older children, we include content around healthcare transition planning. Next slide, please. One of the biggest drivers of our content is what our Title V and our state partners who work within the Title V universe need. And we are the source for 20 of the Title V performance and outcome measures. Some of them are bolded here as they may be of particular interest to this work group. We're also the data source for 15 healthy people objectives, We remain a foundation for much of the work that the CDC does in their National Center for Birth Defects and Developmental Disabilities. And we are a benchmark for our home visiting and Healthy Start programs and some of their performance measures. And obviously we retain the CSHCN score, and so we're the primary data source for children with special healthcare needs, prevalence and impact. Next slide, please. Just to give you a sense of the utility of the survey, these are just a snapshot of a couple of the ways that the survey data get used. Sometimes we're very intimately involved in this kind of work, so we are the data source for the state estimates that our WJF puts out every year on childhood obesity, and we usually run those data with them and help them make decisions about what should be presented. In other cases, we find out with the rest of the world. So when Starbucks used our family impact data to make changes to their personnel policy, we found out with the rest of the world on CNN. But we will take any use of the data, and we're grateful that both the public and private sector are able to use these data to improve both our understanding of the health status of kids, but also their needs. Next slide, please. So that's just a really high overview of the survey. I want to turn it over to Julie to provide a little bit more in depth on the health conditions that are in there and some of the other indicators that we have.
Awesome. Can everybody hear me okay? Okay. So this slide gives you a sense of where genetic and inherited conditions fall among the overall prevalence of current and lifelong health conditions among children. So in 2018 and 2019, allergies were the most commonly reported health condition among children at 19.6%, followed by ADD and ADHD at 8.7% and anxiety at 8.5%. So other genetic and inherited conditions fall at number 9 at 3.8%. Next slide. Taking a closer look at heritable conditions, this graph compares 2018-2019 estimates with 2016 and 2017 estimates in the blue. At the top, other genetic conditions increased from 3.02% to 3.78%, and that was a statistically significant increase. But there were no statistically significant differences in the percentages of children with blood disorders, Down syndrome, or cystic fibrosis. Next slide, please. In 2018, questions about newborn screening were added to the blood disorder and other genetic inherited condition questions. You can see them there outlined in the red. Were any of these blood disorders identified through a blood test done shortly after birth? These tests are sometimes called newborn screening. Next slide. And these pie charts show the percent of children with blood disorders and inherited conditions who were identified by newborn screening. So the blue sections represent the percentage of children who were identified by newborn screening, and the red sections represent those not identified by newborn screening, so a different way. So among children with genetic and inherited conditions on the left, 20.2% were identified by newborn screening. And among children with blood disorders on the right, 66.4% were identified by newborn screening. Next slide. So this graph shows the differences by household income, insurance type, education, and maternal age. The blue bars represent children with genetic disorders who were identified by newborn screening, and the red represents the children with blood disorders who were identified by newborn screening. The percent of children identified by newborn screening decreased as income increased. And then more children with public insurance were identified by newborn screening than children with private insurance. There were no major significant differences based on education or maternal age. The numbers, I'll just note here that the numbers for maternal age were quite small. So even though it looks as though, you know, the percentage of children identified by newborn screening were much higher among women who were 42 and above, those numbers were very small, so they are unreliable. Next slide, please. These graphs show the percent of children with blood disorders or inherited conditions who have 0, 1, or 2 functional limitations. So the National Survey of Children's Health captures 12 functional limitations. These are difficulty breathing, eating and swallowing, digesting food, using hands, moving around, difficulty concentrating, walking upstairs, dressing, doing errands, or if they have chronic physical pain, deafness or problem hearing, or blindness or problem seeing. So on the pie graphs, as the number of functional limitations increase as the color gets darker. So for blood disorders on the left, a majority of children, 53.7%, had no functional limitations, 19% had 1 functional limitation, and 27.3% had 2 or more. Among children with genetic conditions, 35.3% had no functional limitations, 26% had 1, and 38.5% had 2 or more. I also wanted to note on this slide that other heritable conditions are not shown just because the numbers are so small, and so the estimates are unreliable. Next slide. This slide shows the percentage of children with each heritable disorder who had unmet needs there in the blue, or whose parents experienced frustration getting care in the red. The black and yellow dotted lines show the percentage among all children to kind of give you an idea of what that looks like. Among children with heritable conditions, children with cystic fibrosis had the most unmet needs for healthcare, and more of their parents experienced frustration getting care. Next slide. And finally, this last slide that I'll show you shows the number of hours per week that parents spent either arranging healthcare for their child or providing healthcare at home. The darkest blue represents reports of children not needing either care arranged or provided. And then the light blue is less than 5 hours, and the red is 5 or more hours. And there's a lot of variation based on the specific health condition. Parents reported the most time spending arranging or providing care at home among children with cystic fibrosis. 32.4% reported 5 or more hours per week arranging care, and 54.3% reported 5 or more hours providing care at the home. Among the heritable conditions, parents of children with blood disorders reported the least amount of time arranging care. A majority of those children did not need or a majority of those children did not need arranging healthcare or providing healthcare in home. Next slide, I'll turn it back over to Reem.
Thanks, Julie. I think what was helpful about those data points is that it really just gives you a snapshot of kind of how you're able to stratify and look at, you know, sort of populations of interest and kind of their health status as well as their needs. Next slide, please. So the next couple of slides are just designed to give you a sense of where you go if you want to get to the data depending on your level of comfort. So this is the HRSA webpage. It really is a one-stop shop to get to pretty much anything either that we've done as internally as kind of a data brief or what have you, but also can get you to all of the technical documentation as well as the data sets. Next slide. This is the Data Resource Center. We fund this out of Johns Hopkins with Dr. Christy Bethel. And what's helpful about this particular website, if you're not familiar with it, it's a great kind of point and click. If you just want to get the quick prevalence of any condition of the 25 or so that we ask about, then you can do that. You can look at national estimates, state estimates, and then there's also an opportunity to do some very simple stratifiers by race, ethnicity, poverty, etc. Next slide. For those of you who are more interested in actually diving into the data, you can download all of the microfiles from the Census Bureau. At this point, we're not releasing combined files, which is probably of particular importance to folks who want to look at blood disorders or genetic conditions that are relatively rare compared to some of the other conditions that we have on the survey. So you would likely need to combine multiple years. You can certainly do that, and we have technical documentation about how you would handle the weighting and how you append the files, et cetera, if you need that assistance. Next slide. And I'm just going to wrap up now with just looking at a couple of the different ways that we are innovating with the survey and some of the new content that you can expect. So here is just a snapshot. It should say, sorry, the slide should say 2020 and beyond, but we have a little bit of new content for 2020. We actually tried to keep it relatively tight. These data will be available this coming October. We're going to be starting to internally look at the data files shortly here. And it is our first year where we had state oversamples, and I'll have a slide on that in just a moment. In 2021, which will go out this June, we have new content that's sponsored on early childhood nutrition. We have some 5 questions related to COVID-19 impacts, and we've added an ACEs item, an adverse childhood experiences item that focuses on discrimination due to physical ability. This is analogous to our race and ethnic discrimination item that's already on there. And we'll be doing a national oversample of young children. So this is coming up. The 2021 sample is likely to be very robust. Even the 2020 actually has about 41,000 observations. So we are really building up sort of a spectrum of sample that you can work with depending on what your research area of interest is. For 2022, we will be revising and finalizing, God willing, our content around early childhood learning. We're adding housing insecurity, as well as some content around disordered eating, parental leave, and urgent care. Next slide. Next slide, maybe. I don't know what's happening. Oh, there we go. Just a quick note on state oversampling. In 2020, we offered our state partners the opportunity to purchase oversamples. And some folks did this because they just wanted to be able to do more robust analyses of smaller population groups, and others, and this is really, I think, more relevant for more than less of the states, they wanted to be able to do sub-state analyses. And so Census works with each state independently to come up with a plan that meets both their budget and their analytic needs. And it costs anywhere from between $20,000 to $500,000, depending on the state and the analytic area of interest. So we are planning, or had a total of 9 in 2020, and are sort of maintaining some and swapping some out as we go forward in time. Next slide, please. And this is just a quick map of where we were and where we think we are headed. Just depends on Pennsylvania and New York going forward. Next slide. This is the national oversample that we'll have of young children. So this is going to be great for folks who really want to dig into not just some of the early learning, but also kind of early childhood behaviors and family behaviors that promote early learning. We have 5 new questions that get at consumption of fruits, vegetables, sugar-sweetened beverages, as well as time spent playing outdoors. And so this is one of those opportunities where the oversample of young children is really raising all boats. So we will have a much more robust sample overall for the 2021 survey. Next slide. And this is just my contact information. You should feel free to shoot me an email, and Julie and I can triage as needed. But again, this is just designed to give you a snapshot. We're happy to take any questions you might have.
Thank you both very much. It was really informative, interesting to find out more about the national survey. We do have some time for questions and comments. We'll start with committee members first, and then we'll go to organizational representatives. Please remember to state your name before speaking, and we'll start with Jeff Brosko.
Thank you. This is Jeff Brosko. And I want to start by thanking you, Reem and Julie, and all your team. This is a national treasure. The ability to get this information and use it is just essential for all the work we do. I wish we could oversample in every state. It's sometimes tricky for our states to figure out a way to pay for oversampling. It's frustrating. I did have a question for you, Julie, in particular about the slide that looked at newborn screening diagnoses that looked at level of poverty. And in particular, I wonder if you've had a chance to look at this, because on one hand, it could be that certain conditions are more prevalent in certain populations, but it could also be evidence that newborn screening helps reduce inequity in healthcare. So I wonder if anyone's really looked at that more closely, and if you have any ideas about it.
You know, I'm not sure if anybody's looked at it more closely. I'll ask Reem, but that did, you know, I did find that really interesting, and I was hoping that you all might be able to explain that a little bit more. I was wondering, the question that came to my mind was, is this saying that you know, if these conditions are not caught with newborn screening, that they go you know, undiagnosed as they get older, or I don't know. I was looking forward to learning more from you.
So this is Jeff Brosko again. We actually did a paper looking at SCID some years ago that showed before newborn screening, we thought SCID was primarily in non-Hispanic whites. And then after a couple of years of newborn screening in California, it turned out it was quite the opposite, that it was Blacks, Hispanics, and Asians who had a much higher level of SCID in the prevalence. And so we think that this is probably about the universal nature of newborn screening, and shows how newborn screening is one of the ways that we improve equity in our healthcare system. But it could also be that these are confounded by who is more likely to have a condition. And so I think it's worth digging into more.
Knowledge, no one has jumped in on that. You know, I think this is one of the areas with the survey where we haven't seen a ton of work done with it. So we'd love to see more, especially as the sample gets bigger and there's more to work with. We'd love to see more work done in that area.
Melissa Parisi.
Thank you. This is Melissa Parisi from NIH. So I wanted to thank you as well for this important work. And I remember when you were talking about adding the newborn screening questions. My question for you is that obviously, as you expand the survey and you want to be adding more questions, at some point you must reach a saturation level where you can't ask everything you want to ask. So what's the process for actually determining when you may retire questions or rotate them off of the survey? And then I guess I also had a follow-on question about the state oversampling and some of the reasons for that. I saw that, you know, you mentioned race and ethnicity targets, but I wonder if there were other reasons why states choose to oversample, and how that process works a little bit better.
Sure, I can take both of those, and there's lots more to say. So in terms of content decisions, you're absolutely right. We're actually very sensitive to the length of time that it takes to get through the survey. We didn't want to be in the same position that NHIS was in, where it was getting at 60 minutes and they were really losing folks. even as an in-person survey. So we're at 37 minutes right now on the web survey. And we know in particular that the instrument for children that are 0 to 5 is the longest, and that because of everyone's interest in life course and early intervention, that is also the place where everybody wants to add content. So we have a pretty robust process where folks, it takes about 2 years, to be really honest. If somebody wants to propose content to really evaluate and actually kind of make it through the gauntlet and get added, it takes about 2 years. So we ask folks first to propose preferably validated questions, usually not more than 1 to 3, sometimes 5. You see places where people have been able to sponsor up to 5. We take that, we do cognitive testing with census every single year of the survey. So we do really try to make sure that everything that is on there works well with a range of respondents. And then we take a really hard look at the Bureau's priorities and populations that we are charged with serving legislatively, as well as the field. And we try to make the best educated decision we can based on the pros and cons. To date, we have very little content that has come off. What we've done is we worked closely with census to try to find efficiencies within the survey design to make it less burdensome. But the truth is we are getting to that place where we're going to have to make some hard decisions. And if content has simply not been used in any sort of papers that we can find, if it's really not a priority area for the Bureau or our close partners, then that's sometimes a place where content would fall off, especially if it's not necessarily content that we feel like is the best way to get at a particular question, or if parents aren't necessarily the very best reporters. So I'd like to say it's a nice linear process. It's not. It's very iterative, and we rely a great deal on our partners in the Bureau. Joan and her team in particular kind of really help us, and others in her position sort of really help us make that determination and make some of the tough calls. To your question about oversamples, we've had states who wanted to really look at children with special healthcare needs in particular, although we do our best. We do have an oversample of kids with special healthcare needs. I think when you really want to drill into that population at some of the more granular level, you still need a more robust sample. So some states have looked at CSHCN status. Some have been interested in particular racial and ethnic groups, and some have been interested in a very particular area of content. They have a governor who really cares about early learning or early childhood, and that's where they want to put their money. I will say this for, I think, Jeff, one of your points about, states wanting to give more states the opportunity to purchase oversamples. One of the things we're trying this year with Pennsylvania is we're allowing them to pull it from their block grant allocation, which for many states, the block grant is what an oversample cost is frankly pencil dust on their block grant, but it's a more streamlined opportunity for them if they want to allocate those funds, and census and our team will work with them to create a plan that is within their budget. Hopefully I answered all of your questions, at least marginally.
All right. Due to our time limitations, May Baker, Natasha, Jacob, and then we'll have to go on to our next session. May Baker.
Sorry, okay. May Baker, committee member. My question is more for clarification. And when we use a newborn screening, I'm more curious because on Junie defined is you identify the detector at birth. I'm not so sure. I just want to be clear because for this group, when you talk about screening, we have a panel in mind. And just based on the data you presented, for example, you talk about the blood disorders. I see the slides, you have a Sickle and thalassemia. Also, you put a hemophilia in that. So it's why you look at that identified from where, because I know hemophilia is not in the newborn screening panel. So could you just clarify when you use a newborn screening doesn't, if I understand correctly, it doesn't mean the newborn screening panel will address?
Maybe we could show the slide again with the newborn screening question.
Yeah, when you get the slides up, so I hope I ask clearly, because you said you have inheritable disorder about the 20 also. So to me, do the math. So I thought maybe when you talk a newborn screening as a conceptual or really indicate the disorder, several disorders that you identified at birth can be done through state newborn screening program, also could be done at the bedside, like in the hospital. I just want to know, I understand what I understand correctly.
Yeah, and I actually, I'm not sure. And Reem, I'm not sure if this was part of this discussion. I know that it says the tests are sometimes called newborn screening, and I don't know if that would, account for that sometimes it's maybe not called newborn screening. But I don't know if you have anything to.
Yeah, so the only thing, so May, I think you're driving on an important point, which is the level of specificity that we're getting at when we ask some of these questions. And one of the sort of perennial challenges we have is that this is a parent-reported survey, and it's self-administered, meaning we don't have the advantage of an interviewer who can sort of ask probing questions or get in any more depth. So the questions you see here are basically the wording that we were able to come up with, working with Joan and her team and others, I believe, who are on, on this call, as well as after we had the opportunity to do cognitive testing and we made sure that parents could actually understand what we were asking. So to your point, it's possible that there is variation in what is being reported. And this, at least in the moment when we fielded this, felt like the best we could get. But we may be missing or mischaracterizing some of the experience of testing.
Thank you.
Mm-hmm.
Natasha Bonham.
Hi, Natasha Banan, thank you. This is great. It's really wonderful to see these questions added in. I have, I guess, a comment and two questions. One, I think it's really interesting to see the data from the cystic fibrosis parents, considering the fact that some would say that that's an area that has had a lot of research and a lot of resources and so much done from a clinical perspective, but also the advocacy perspective. So that's just something that could be interesting to try to unpack. My two questions, one's a technical one. For the other conditions, when you go into the database, are you able to see all of what was kind of written in terms of other conditions? Is that available, or is that all collapsed under other genetic conditions?
So for that write-in, you would have to go in to the one of the RDCs. It's not on the public use file, so you'd have to get, write a request and get in there. I have not, just from a resource perspective, our team, we're actually a pretty small team of about 5 people running the whole survey. So we have not had a chance to dig into the write-ins. But I think that's obviously an option and something that you could propose to do.
Great. And then lastly, do you ask any questions about prenatal diagnosis? I think at a time now when there's a bit of an overlap between prenatal diagnosis and what you can be diagnosed with through newborn screening and early childhood. Just seeing if there's any information there, even though.
That's a really interesting question, and one that actually just amongst our team, many of us are parenting young children and have been pregnant between the time that the 2016 survey was written and then even the 2020 questionnaire. And the uptake of like early prenatal screening is really different, even in that time period. We've been debating whether or not we should add content on that. We weren't quite sure what the content should be yet. So it's on our radar. We just haven't figured out exactly how to do it. And if you have thoughts, we would love to hear it. So we're always open to that.
Absolutely. Great. Thank you so much.
Jacob Hogue.
Yeah, I think more of consideration on top of what you're just speaking of, as well as about Jeff's question. I wonder how much the general accessibility of prenatal diagnosis and preconception testing and screening is influencing that difference that you're seeing based on income level, where I think, fortunately, newborn screening is a universally available testing modality, but there's certainly differences in access to care for prenatal testing. So those families that feel that the condition was identified based on newborn screening is probably different in populations that knew they were carriers for those disorders based on having the accessibility to that testing previously. So I wonder how much that's influencing that difference rather than being a difference in the rates of those disorders in those populations. Thank you.
Chris Cuss.
Yeah, you had mentioned in the 2021 survey, you're going to have 6 questions about COVID-19 related impact. Can you give me a sense of that or any feel for what those questions would be?
Sure. Yeah, so what we did is we've added some content, and it's the timing is a little challenging, but it was the best we could do under the sort of timing of the pandemic, to be honest. So we added content around missed preventive care and the reasons for the missed preventive care, not just COVID happened, but my doctor's office was closed, my kid had COVID, things like that. So we asked questions about that. We asked content around, let me just grab it really quick, around childcare disruptions. So we also wanted to get at that. And I'm just going to check the last one. Let me send a follow-up on that. I apologize. We have questions in the Household Pulse survey as well. So for those of you who are familiar with the Household Pulse survey, so we're just pulling in those data too. Oh, I'm sorry. The last set of items are around telehealth. So whether or not your child received telehealth different from what you would normally receive. And we tried to match the NSCH questions with what we were putting in the Household Pulse survey. So we'd have some comparison of kind of real time of what's been happening in the last couple of months to what actually we see once we get in the field in June.
Thank you. And I'm told by Mia that we do have a few more minutes if anyone else has any questions or comments before we move on.
I wanted to make one, if it's all right, just go back the sort of commentary larger about how we add content, but then the last comment about, sort of parents' access to either prenatal screening, that kind of thing. One of the other things that we really look at in terms of services when we ask questions about it is whether or not the Bureau has a particular responsibility for ensuring access to something. So there are any number of services we could be sort of tracking to see if parents have access to, but it's not always in the Bureau's lane to make a change in that area. And so that's one of the things. We do have a fair number of items around developmental screening and things like that, but we haven't necessarily gone into the prenatal screening lane. And I think some of that is that we're still trying to figure out what is our role. And perhaps that's a unique space that this committee in particular sits, is sort of what is the role of the Bureau? What should we be promoting? And what are we accountable for ultimately? Which so doesn't mean we don't add things purely for the scientific or the research sort of purposes, but we often also then track it to what would we do with those data? What are the policy and programmatic implications of the data?
Jeff, did you have another?
I guess if we have time, this is Jeff Brosko. Following up on Reem, what you just said, because I also, like Natasha, was struck by the difference in reported need by parents of children with cystic fibrosis. So, you know, in some ways that might be a research question, right? So Natasha and I could write a grant and do some qualitative research. But do you do that as well? Do you sort of, to understand what your questions mean, follow up with some families to see, you know, that's the question about unmet need is always a really tricky one because people's perceptions of what they need might be all over the place. So do you get a chance to do that kind of research as well?
That's a great question. We have not for some time. And I think to your point, yes, what you say is unmet need really depends on what you think you should be getting in the first place. And we know that wealthier parents have a different perception of what they should be getting. And so there is a subjective nature to a lot of, I mean, that's one of the strengths of the survey, right? Because you're getting parents and like what they really think. And I think you always have to take a lens to say, well, why might they think that in the first place? So what I would say is that in my experience running a survey, what I found is that we can pay for kind of standard usability, kind of feasibility testing that we do with census every year, which is like, can people actually get from point A to point B in your survey, right? And then I think it's honestly what we found is you really almost have to put out a separate pot of money and pay someone else to do that much deeper dive. That's sort of a true cognitive testing where you're really pulling out like, what are the themes? What are you really hearing? You can do really a much more targeted recruitment than you can for something. And we are doing that for Healthy and Ready to Learn with the National Center for Health Statistics Cognitive Interviewing Lab. That was sort of by chance. We had some extra money and we were able to do that. But I would argue that you probably need that kind of testing as well as the regular usability testing. And they're just different lines of investment, if I'm honest.
This is Kamala, just to jump in on that. I think there's been some work on those unmet need questions, Jeff, from other surveys, because those are standardized questions. And so you may be able to, because I think they have done some deeper dives with regard to validity and really, are we all thinking the same thing? And those kind of questions that I think Reem is referring to. So.
Joan, Scott?
Yeah, this is Joan Scott from Hersa. I just wanted to note, you know, one of the original reasons we added the newborn screening was at the, you know, suggestion of the committee to see whether or not this was a vehicle where we could say something about the long-term outcomes for individuals and children who had been detected through newborn screening. And so some of our initial forays in it was to see what kind of data we could get out. And, you know, is there a way that we can massage it or improve it going forward, and how we're asking it in order to address a question that the committee's been asking for a long time about, you know, what can we say about the long-term impacts? Of course, the problem is that the rarity of some of the conditions that are, you know, individually on the RUS, you know, it's difficult to say anything about the individual conditions, and that's just a limitations. But certainly welcome any suggestions from committee members about, you know, how we could potentially look at the survey and improve our abilities to say something about the long-term outcomes for kids.
Thanks. Dr. Gandor, Dr. Donnie, thank you once again for sharing this information with the committee. Clearly, it's an area of great interest and of opportunities. So we appreciate your being with us today. Next, as you know, the committee has undertaken a review of its evidence review and decision-making processes. In February of 2019, the committee initiated this project by convening an expert advisory panel to consider the key components of the review. In 2020 and 2021, the committee continued to gather information on ways to strengthen the evidence review process, including an examination of its nomination form, assessment of stakeholder values, newborn screening, decision-making criteria, and the decision matrix and review of added RUSP conditions. The committee is working to finalize the updates to these processes, and today we will have the opportunity to gather stakeholder input through public comment. We received one written and one oral request to comment on this topic. The American Society of Gene and Cell Therapies urged the committee to collaborate with the FDA, ensure the RUSP keeps pace with treatment approvals, and ensure the process to review conditions nominated for inclusion on the RUSP is transparent, predictable, and timely. We will now hear from Elisa Seeger, who registered to submit oral comments. She has also submitted a written version of her remarks, which was disseminated to the committee. Ms. Seeger, the floor is yours.
Thank you. Dear Chairwoman Powell and members of the Advisory Committee for Heritable Disorders in Newborns and Children, on behalf of the over 30 million Americans living with rare diseases, and as co-chair of the Every Life Foundation's Newborn Screening and Diagnostics Working Group, I am pleased to offer the following comments to inform the Advisory Committee's ongoing conversations about the review process for new RUSP nomination packages. The Community Congress is a forum for collaboration across stakeholders, representing over 200 individual rare disease patient advocacy organizations, in addition to over 90 other healthcare and biotechnology organizations. Our Newborn Screening and Diagnostics Working Group is dedicated to ensuring that the rare disease community receive the earliest possible access to life-saving diagnostic opportunities through newborn screening and other diagnostic tools. Our communities work for many years with experts to develop a newborn screening system and infrastructure around our disease community. We invest in developing care standards and screening tools and conducting pilots, and then work to help lead the compilation of a nomination package that meets the evidentiary requirements for the RUSP. We understand that the periodic review of this process is necessary to ensure that standards are current and rigorous. As you proceed, we hope the review and implementation of an updated evidence review process continues to be conducted in a manner that is transparent and inclusive of patient community members as key experts. We'd like to thank you for today's public comment period dedicated to this topic. To inform your activities, we offer the following comments. As the Advisory Committee seeks to update your review process for newly nominated conditions, while also considering a new process for assessing implementation and outcomes for conditions previously added to the RUSP, it is important to ensure that any new functions of the Advisory Committee can occur without sacrificing the pace or the quality of the review of newly nominated conditions. Both of these committee roles are important to the future of newborn screening, but neither should inhibit the ability for the other to occur. As an organization dedicated to supporting patient advocacy groups that are leading newborn screening programs, we are aware that numerous strong nominations will be submitted to the Advisory Committee in the coming years. As you prepare for an increasing number of RUSP nomination packages, we urge the Advisory Committee to develop a strategy to ensure that no conditions review is delayed due to the lack of resources to review new packages. As you are aware, communities work for many years to develop newborn screening systems and develop the evidence required for a RUSP nomination. We request that the Advisory Committee considers these communities when considering any changes made to the evidence review process. In addition, we ask that you consider a transition period rather than a specific transition date for enabling a phasing of any evidentiary requirements, changes, and updates. We are pleased that the advisory committee is requesting feedback about the educational materials that will accompany the update to the review process. These materials will help ensure the newborn screening community understands and adapts to the changes and that no community is left behind because they were unaware of the updates to the evidence review process. The revisions to the review process will impact stakeholders across the newborn screening system. For these reasons, we suggest the advisory committee to create a variety of educational materials for newborn screening stakeholders, identifying changes to the evidence review process and how those changes impact specific communities throughout the entire newborn screening system. Creating a collection of education materials will help to ease the transition from the current evidence review process to the updated review process. To accomplish these educational goals, we encourage the advisory committee to establish a multi-stakeholder working group to include representatives from the patient community to inform the development and dissemination of these materials. We appreciate that the COVID-19 pandemic has placed even greater demands on the precious time of our newborn screening leaders, and we are grateful for your unwavering dedication to our rare disease patient communities. The Every Life Foundation and the membership of our Community Congress Newborn Screening and Diagnostics Working Group stand ready to support your work, and we look forward to engaging with you over the next coming months. Thank you.
Thank you for your comments. Next, the committee will break and return at 11:40 a.m. Eastern Time. Welcome back, everyone. We're going to start out by taking roll once again, starting with our committee members. Kamala Mistry.
Here.
May Baker.
Here.
Jeff Brosko. Kyle Brothers.
Here.
Jane DeLuca.
Here.
Carla Cuthbert.
Here.
Kelly Kelm.
Here.
Joan Scott.
Here.
Sean McCandless.
Here.
Melissa Parisi.
Here.
And I'm here, Cynthia Powell. Anna Marie Saranen.
Here.
And Scott Schoen.
Here.
And our organizational representatives, Robert
Jeff Brosko, I'm here. I just couldn't find my mute button.
Okay,
My
thanks.
apologies.
Robert Ostrander.
I'm here. Power was off here all morning, but we got it back finally.
Oh, that's good. Deborah Friedenberg.
Here.
Maximilian Munke. Stephen Ralston. Jed Miller.
Here.
Susan Tanksley.
Here.
Chris Cuss.
Here.
Shakira Henderson. Jennifer Kwan.
Here.
Jacob Hogue.
Here.
Natasha Bonham.
Here.
Sean Dolan.
Here.
Kate Walsh Foxley.
Here.
And Georgianne Arnold.
Here.
Thank you. If I could have the next slide, please. Let's see, I think I had some introductory slides that we were going to use. Okay, well, while we try to bring those up. So our last session of the meeting is going to be on the newborn screening workforce, short and long-term follow-up. The newborn screening workforce continues to adapt and evolve to challenges and new demands in the field. Thank you. It's critical for the committee to stay apprised of current and future issues facing the newborn screening workforce. During today's panel, we will have an opportunity to explore issues pertaining to the short and long-term follow-up workforce. We'll hear speakers spanning the continuum of follow-up services from the American Board of Medical Genetics and Genomics, the National Society of Genetic Counselors, the Child Neurology Society, and the Sickle Cell Disease Treatment Demonstration Program. Before I turn it over to our panel of presenters, I'd like to frame the discussion with some background information. Many experts and professionals comprise what we think of as the newborn screening workforce. Typically, those include genetic and metabolic specialists, primary care providers, public health professionals, which includes all public health laboratory staff and follow-up staff. Additional medical specialties and hospital staff play a pivotal role as well. The current and future status of the newborn screening workforce is a key component to the success of newborn screening from screening through diagnosis. The conversation today is a starting point for ongoing discussions and will focus on genetics providers, other specialty providers, and an advanced practice provider model being utilized in sickle cell disease programs. At future meetings, we hope that subsequent conversations will delve into the important role of other professionals. These include others in the public health domain, our metabolic dietitians who provide care, ongoing day-to-day care for patients with inborn errors of metabolism, and who are critical in devising appropriate standards of care for those patients. We also would like to include audiologists and otolaryngologists who are critical in the diagnosis and treatment for patients identified with hearing loss through newborn screening. There are many other healthcare professionals involved now with the care of infants identified through newborn screening, including endocrinologists and cardiologists, as just a couple of additional examples. Next slide. By way of recent background, in 2019, the HHS Labor Appropriations Bill included language asking the GAO to conduct an analysis of the medical genetics workforce in order to report what is known about the changes in the size of the genetic counselor and medical geneticist workforces, and what is known about the geographic distribution of these workforces. Dr. Herrera Butler of Washington requested the GAO to conduct this workforce study. The American College of Medical Genetics and Genomics and the American Board of Medical Genetics and Genomics partnered to survey the field of board certified or eligible geneticists in the United States to provide information and data to the GAO. The National Society of Genetic Counselors and the American Board of Genetic Counseling provided data and information to the GAO. The GAO interviewed officials from HRSA, NIH, and the Bureau of Labor Statistics. The GAO interviewed 2 of the 7 HRSA-supported regional genetics networks. Next slide. The GAO report shows the steady rise in the numbers of genetic counselors and a more modest trend in the number of newly certified medical geneticists, which reflects the reported average of 7 genetic counselors and 2 medical geneticists per 500,000 individuals in the United States. Next slide. The other key findings from the GAO report are that there is wide variability in the numbers of genetic counselors and medical geneticists across states, and that most are found in hospital settings. So what does this mean for newborn screening? Next slide. GAO data represents data for both professional groups across all disciplines beyond newborn screening. We know that as we add additional conditions to the RUSP, the needs will vary greatly. I think we're, faced now with, the need for more neurologists, and we're fortunate today to have Dr. Kwan talk to us more about that, because that's a group that in the past has not been that involved in the short and long-term follow-up care for children with conditions identified through newborn screening. We know that as the complexity of follow-up care increases, how is that going to impact the committee's decision-making regarding a recommendation of new conditions? If parents are going to be faced with the challenge of having to travel perhaps thousands of miles to seek appropriate care for their child who's been diagnosed with one of the conditions. So today's presenters will explore the challenges and opportunities that lie in the newborn screening workforce, and will provide an important starting point as we explore the newborn screening workforce across future meetings. With that, I would like to welcome our first presenter. Dr. Miriam Blitzer is the CEO of the American Board of Medical Genetics and Genomics. She also holds an appointment as professor in Division of Genetics in the Pediatrics Department at the University of Maryland School of Medicine, and was division head for 20 years. She has been active in state and national work, including having served as chair of the Maryland State Advisory Committee for Inherited and Congenital Disorders. Dr. Blitzer has served on many boards, including the ABMGG and the American Society of Human Genetics. I'd now like to turn it over to Dr. Blitzer.
Thank you, Dr. Powell. Can you hear me?
Yes, we can.
Okay, great. And I really appreciate you and the entire group inviting me to participate and share a bit of data with this group. I think hopefully I'll set some foundational information for everyone to move forward. I'm going to focus today's talk mainly on clinical geneticists, and I'll describe that as I go forward. Next slide, please. Sorry, I was trying to change my own slides. I start every one of my talks just to remind you what the American Board of Medical Genetics and Genomics is. Our mission is specifically to serve the public and the medical profession by establishing professional certification standards and promoting lifelong learning as an excellence, as well as excellence in medical genetics and genomics. So as a medical board, we, like our other medical boards that we work with, certify individuals who have met rigorous standards to become board certified in our field, and work with them to continue lifelong learning to keep their excellence in their process. Next slide, please. So who are we? Just to give you a brief overview, we are an independent medical board. We were established 40 plus years ago. We evolved out of a need that was recognized by leaders in the field to improve the level and standards of clinical care in the area of medical genetics. And if you think back 40 years, genetics was a relatively new clinical science. It had been a research one and was transitioning into the importance of a medical profession. And it was felt that starting an independent board was important in order to do two things. One, to certify medical geneticists, which documents their expertise in their field. This included at that time, 40 years ago, clinical geneticists, who I'm going to be referring to. These are MDs who practice in the field of medical genetics. Clinical laboratory geneticists, which at that time included biochemical geneticists, running diagnostic labs for inborn errors of metabolism and cytogeneticists. And at that time, ABMG certified the genetic counselors as well. And they certified individuals with specialized training, defined clinical skills, and expertise. The board also accredited training programs. Up until the establishment of the board, the residencies and fellowships were not accredited and standardized, and this was considered a really important need. Next slide, please. This evolved such that in 1991, approximately 10 years later or 30 years ago this month, ABMG was accepted as the 24th board into an organization called the American Board of Medical Specialties, which is an overseeing organization. It's a federation of all the recognized medical boards, such as pediatrics, internal medicine, maternal fetal medicine, psychiatry, neurology, and the like. So we were the newest board at that time. We still actually are the newest board. There has not been another specialty accepted by ABMS since that time. The other thing that happened is accreditation of our programs. Our residency programs transitioned over to another organization called the ACHDNC, which accredits all residency and fellowship programs in medicine for the other boards and ours as well. And our laboratory training programs over the last 3 years have transitioned over to ACHDNC for accreditation as well. Next slide, please. Just to give you one more background slide before I get into some of the data I have. ABMGG, that's us, that's the board. And like all medical boards, we set the standards that are required to be able to sit for the initial certification examination. We deliver and administer the exams for these individuals, and we set the standards and administer programs for maintaining your knowledge base and continuing certification for all of our diplomates. I'm going to mention the college, the American College of Medical Genetics and Genomics, which most of you are familiar with. The ACMG is a membership-based professional society. It's the professional society for medical genetics and genomics. They're the providers of educational and learning activities. They advocate for their members and fellows and the clinical profession. So we work collaboratively. We're connected to one another, but we are parallel in our missions and different. Next slide, please. Okay, now the board certifies individuals in clinical genetics and genomics. That's the MDs, and that's where I'm going to focus the rest of my talk on. We also have a subspecialty in medical biochemical genetics, where individuals who are clinical geneticists can get additional training and focus their practice, which is very important for this group, on inborn errors of metabolism and certainly all those disorders that are identified through newborn screening. We also certify laboratory geneticists in the diagnostics labs for biochemical genetics and the specialty of laboratory genetics and genomics, which is a merger between cytogenetics and molecular genetics. Next slide. The residencies, and I bring up how we train our MDs very briefly because I think this is where the workforce challenge comes in. To become a medical geneticist or a clinical geneticist, you have to complete a 2-year accredited residency, which requires an additional pre-year of residency in another field with a 12 months of direct patient care. Or you can complete what we call a combined residency. Combined residencies are approved by 2 specialty boards like American Board of Pediatrics, American Board of Medical Genetics, where we have approved combined training for 4 years. And at the end of that training, the physician is able to sit and become certified in 2 specialties. And these are the different areas we have. This has been actually a way we are seeing an increase in the workforce. Next slide. I'm just going to say that we have this many accredited programs 46 around the US. That's a relatively small number. And the biggest goal that we have is to recruit more clinical geneticists into these areas. Next slide. I'm going to sort of ask you to look at the far right. These are residents. We're looking at pipeline here, which is our very important component. And if you look at the far right, it says how many residents are in training programs. From our standpoint, there's been a significant increase from 14-15 to this current year, from 129 to 161. We're not talking large numbers. That's a large increase, but when we think about the numbers, they are relatively small. Next slide. This is a slide with a little bit more detail than the one that Dr. Powell showed from the GAO report. We provided directly from the board a fair amount of data to GAO. And this is showing the numbers of newly certified clinical geneticists in the last 10 years. And are we seeing an increase? Yes, we are. We're hoping that this will continue. We give our exams every other year, so they are given in 2 months from now or 3 months. Our numbers are still small because these are every other year exams, but we are starting to see an increase. The question is this significant enough at this point, and then how long will this take? Next slide. I know these slides have been provided to you, but basically this is at the top line, it says that there are currently 1,240 clinical geneticists in the US. These are practicing, taking out retired, taking out deceased, and these data will be updated. This is the data we submitted to the GAO. This will be updated this year. This will likely increase. If you look at the bottom, from our inception as a board, what you're seeing here is the clinical geneticists in practice in red compared to those that were certified that year. And you'll see that, as expected from the early years, a fair number of individuals have retired or have died. And we are starting to see a maintenance of clinicians going forward. And obviously this is going to depend on maintaining and seeing how we're going to increase these numbers. Next slide. I'm going to skip this slide, which just shows some of our demographic breakdown, and show it a little differently on the next slide, please. This shows just where we are right now with non-retired clinical MD geneticists who we know are in practice. And just to give a hint, because I think looking at our workforce, and the big focus for the ABMGG in the next 2 years is going to be defining our workforce in much more detail and working with our professional societies on recruitment. This is not really surprising for those of us in our field. We actually are a predominantly female majority, I should say, female for clinical geneticists. We are not very diverse, and this is a concern of ABMGG and our specialty, as it is for any medical specialty at this time. And this is an area that we are beginning to focus on. And we are also right now looking at the data for our pipeline, our trainees, in comparison to our diplomates now. And it also impacts, and we're also looking at scope of where people are practicing. Next slide. So Dr. Powell mentioned this, and this is just an updated graph of what we had submitted to the GAO as far as where are clinical geneticists and how certainly are they going to be able to provide services, especially for follow-up of newborn screening, depending on where they're located. Not a surprise to us in the field, but also a concern is if you look, there is a number of states that have 1, 2, or only 3 geneticists for their entire state. And obviously there is a concentration in particular areas, and certainly in the major academic centers, as Cindy mentioned. And we have one state, as you can see, with no clinical geneticists practicing currently in that state, at least according to our last run of these data. We'll rerun these data again after our next certification exam, and it will be a bit more specific. Next slide. So as Cindy also mentioned, the ABMGG and the ACMG did a workforce study in response to the GAO. The data the board provided the GAO was not through the survey, it was complete data. Survey data always is a little more difficult or challenging to interpret. But this paper, these data were published a week and a half ago on May 3rd in Genetics and Medicine. In this survey, there were almost 500 clinical geneticists who responded. And the data, I think, were fairly telling in the sense that the average work week was 50 hours. And we went through in this looking at the wait time for new patients, which is significantly long, location, and I showed you the map, and the amount of clinical duties. I will say that telehealth and telemedicine has been helpful in genetics, and we were able to sort of manage the COVID epidemic, pandemic a bit better in our field, but certainly the duties are really challenging here, especially with newborn screening in the sense of looking at how do we get patients in because they're emergency patients. Conclusions from this are very straightforward, that there's a gap between genetic services needed and the workforce capacity. And this is where the concerted effort really needs to be made. Next slide. I think that is my last. Cindy, Dr. Powell, I don't know if we're holding questions to the end, which I am guessing.
Yes.
Welcome to answer.
Thanks very much, Dr. Blitzer. And we were going to hold questions and have a general discussion after all of our speakers have presented, if that's okay with you.
Perfect.
Next, we will hear from Kate Walsh-Foxley, who serves as the committee's organizational representative from the National Society of Genetic Counselors. Ms. Walsh-Foxley is a senior genetic counselor at UPMC Children's Hospital of Pittsburgh, Division of Medical Genetics, and is certified by the American Board of Medical Genetics. Her current clinical interests include genetic counseling for inborn errors of metabolism, especially newborn screening disorders, and working with the plain communities of Western Pennsylvania. Other interests include genetics education and the ethical implications of clinical genetics and genetic testing. And I'll turn it over now to Kate.
Great. Thank you, Dr. Powell, and thank you to you and to the committee for bringing this topic to conversation. I think it'll be so essential as we continue to add to the RUSP. My conversation is perhaps a little bit more applied and a little bit more specific to newborn screening as we look at genetic counselor workforce and needs. Next slide, please. Next slide. I thought it was important to start our conversation by looking at what roles genetic counselors do currently play in the field of newborn screening. We actually do a professional status survey on an every 2-year basis through the NSGC. And while it lists a very small number of genetic counselors in newborn screening and in public health, I think that reflects the fact that many genetic counselors have newborn screening as a part of their work during their activities, that not too many genetic counselors are only working solely in newborn screening, because I've had many conversations over the last 2 months with people who don't see themselves as primary newborn screeners. So lots of under ascertainment of the workforce, I think, there. But if you look at genetic counselors who fill roles in the newborn screening system, we have genetic counselors working everywhere from the federal genetic services programs through the regional genetics networks that have been mentioned several times during this meeting, coordinators of state genetic service programs, serving on state newborn screening advisory boards, patient advocacy programs, A lot of genetic counselors working as laboratory liaisons through the private and state-run newborn screening laboratories. Many genetic counselors who work with families who are referred because of a positive newborn screen, both for short-term and long-term continuity of care relationships. We also have genetic counselors who work in clinical research and clinical trials for disorders that are identified through the newborn screening programs, and also some who work supporting therapeutics for patients who are identified. So really across the spectrum of the newborn screening system. Next slide, please. So I'm going to focus on some workforce challenges for genetic counselors in newborn screening. Next slide. A lot of these will focus on educational needs for the various people involved in newborn screening. Certainly families need to be informed about new diagnoses or new potential diagnoses, other healthcare professionals who are not familiar with these disorders, and even the newborn screening workforce in the laboratories may need to be informed about newly added conditions. We certainly need knowledgeable informants to work with families, what we call families in waiting. People who are identified, depending upon the state screening protocols, may have a positive biochemical screen and need to have follow-up testing, certainly confirmatory testing at a minimum. Families may have significant wait times and may have many questions. The addition of Pompe and MPS1 have already significantly increased need for individuals knowledgeable about these disorders and about the molecular genetics, not only of the genes involved, but pseudodeficiency alleles and similar issues. Cascade testing has also become a big issue for conditions as they're being added, particularly in the early time frame for conditions like Pompe, ALD, and SMA, because there may be family members who are young enough yet to perhaps be affected by one of the later onset variants who are candidates for screening. Diversity, as Dr. Blitzer mentioned, for among our providers is an important issue, as well as we serve a more diverse and complex population seeking care. And this impacts not only clinical care, but also public health with a variety of different diversity issues. And then, as I mentioned, we need individuals who are knowledgeable about clinical trials for conditions on the RUSP, as more and more therapeutics are being developed for these conditions. Next slide, please. Another issue that came up frequently as I talked to my colleagues was one of the need for competitive compensation based on training, experience, and skills. And this impacts both public health and clinical care. There's a lack of defined positions for genetic counselors in public health. Oftentimes, genetic counselors are taking coordinator positions or administrative positions that don't acknowledge their degree and their skill level. This affects not only retention of more experienced counselors, but even entry-level positions where it's difficult to recruit knowledgeable individuals because of salaries that are not competitive. There's also a need for promotion opportunities or a job ladder. There's also lack of defined civil service positions for genetic counselors. We acknowledge in all of this conversation that state programs are certainly under-resourced, but we need to look at more creative ways to fund these positions so that we can compensate people for their skill sets. And all of this is impacted, of course, by the limited number of MD geneticists, certainly those in biochemical genetics, to do the follow-up work that these families need. Next slide, please. Just a little bit more information on some of the salary issues. If you look at, again, small numbers with this survey, we had about a 50% response rate and only a small number of newborn screening and public health. But if you look at median salaries for counselors who identify as working in newborn screening and public health as compared to all counselors reporting, there is a significant difference in compensation that we would like to see improved. Next slide, please. So looking at present and future solutions, genetic counselor activities in newborn screening. One thing that some programs have been doing is looking at increasing prenatal newborn screening education for families. We had a pre-conference symposia around the NSGC meetings a number of years ago, targeting prenatal genetic counselors who discuss screening throughout pregnancy, and we hope can integrate inclusion of newborn screening education in the prenatal genetic counseling setting. Time is an issue for these people because they have lots of different things to talk about. There have also been a number of innovative solutions for newborn screening education that are being developed. Some of our students particularly have been very creative with chatbots and iPhone applications, and there are many developed videos developed or in development that have been done by genetic counselors. Hawaii, if you're not familiar with the materials available there, this is a project of the Western States Regional Genetics Network, not NSGC specifically, but involved quite a number of genetic counselors. They've developed parent fact sheets and are in the process of developing new videos, all done by genetic counselors in conjunction with specialty care providers. And the link there will take you to those. If you look at the ALD one in particular, that one has a new video that's just been developed. Next slide, please. We also have information from some of our colleagues about families expressing frustration about notifying providers not always being knowledgeable about the condition in question. Certainly GCs have, genetic counselors have training and expertise in delivery of high anxiety news that can be very effective in that setting. As more and more molecular results are being included in some states with the first notification of results, families are asking for explanations about this, as are primary care providers who may choose to inform the family, but have a need for some background information that they may not have had in their training before communicating with the families. And in many areas, genetic counselors are providing some of that information to primary care providers. There are also genetic counselors who play a role in helping to do risk assessment and look at needs for immediacy of referral as conditions with broad phenotypes are added to the RUSP and the state newborn screening panels. Next slide, please. Genetic counselors are also being asked to provide ongoing support for families. Not all clinics have, most have nurses involved, not all have social workers as part of that team, of their teams. And genetic counselors often fill multiple roles, including genetic counseling, care coordination, and the cascade screening that I mentioned earlier, looking at family members who may be at risk. As lysosomal storage disorders are added, I think this has become a real issue and may continue. Other genetic counselors that I've talked to play a role in quality improvement and quality assurance within their state systems, working to decrease false positives as we learn more about screening for some of the lysosomal storage disorders, and also play a role in providing follow-up data on short and long-term follow-up for state systems so that assessments can be done to look at allocation of resources for family needs. Next slide, please. Much like what Dr. Blitzer talked about, there has been an increase in the number of genetic counselors who are being trained. There's been an exponential growth in training programs in the last 5 years, and we now have 55 total programs with a student enrollment of increased by 52% and a professional growth rate of over 100% in the last 10 years. And it is anticipated that this continues. There are now over 5,000 practicing genetic counselors, and while not all of them are in newborn screening, obviously, that number is growing as well. There has been an increase in metabolic and newborn screening curriculum content in some programs. And also there are development of CEU materials for previously trained genetic counselors in newborn screening and metabolism. There also is a long-standing focus on public health in the University of Pittsburgh program. So students are being trained in public health as part of their genetic counseling training. And next slide, please. Our focus in diversity, we have a strong commitment on improving the diversity in our field. the organization commissioned an assessment by an external group, the Exeter Group, looking at current diversity issues and are in the process of developing a 5-year organizational plan. As has already been mentioned, NSGC also is contributing to the Genomics Workforce Diversity Initiative. And there are several programs in place already that are very effective. There's again, Western States Regional Genetics Network has been active in a Minority Genetic Professional Network. And there are 800 current members that support and mentor minority students into the field and support those already in the field. There's also a newer program out of Arcadia, now University of Pennsylvania training program. Erica Price, who's a recent graduate, developed the Golden program, and that also supports young minority students who are interested in the field of genetic counseling. Next slide, please. As far as the compensation goes, and I'll just go through this briefly, NSGC has had a number of legislative efforts to increase access to genetic counseling services. House Bill 2144 currently before the House of Representatives, and Senate Bill 1450 just introduced about a week and a half ago, look at GC reimbursement for services for Medicare and CMS. And while this may not seem relevant to newborn screening because it doesn't address pediatric reimbursement necessarily, we believe that there will be downstream effects because hospitals will be able to bill for genetic counseling services, allowing them to hire more genetic counselors, allowing genetic counselors in private practice to bill. And also this may encourage other covering entities like Medicaid and private payers to pay for genetic counseling services, thus increasing access to genetic counseling services. Next slide. I have a couple of supplemental slides. Next slide. First, I'd like to thank some of my colleagues who contributed to the presentation. Next slide. This is just ABGC diplomats by year from 1982 through current, as I said, over 5,056.29 currently board certified genetic counselors. Next slide. A representation of the output from the Exeter Group JEDI assessment that you can review at your leisure. And then one more slide, I believe, is the link to the information from the Western States Regional Genetics Group patient or family education brochures, and they are really comprehensive and very nice. And as I said, people are welcome to utilize them and the YouTube videos to share with their patients as long as acknowledgement is given to the team that produced them. And I'll stop there and wait for questions at the end. Thank you.
Thank you, Ms. Walsh-Foxley. Next, we will hear from Dr. Jennifer Kwan, who serves as the committee's organizational representative from the Child Neurology Society. Dr. Kwan is an academic child neurologist with a strong interest in improving long-term clinical outcomes in children diagnosed with rare disorders by newborn screening. She is currently at the University of Wisconsin, where she is the director of the Pediatric Neuromuscular Program at the American Family Children's Hospital, which is a Muscular Dystrophy Association care center and a Parent Project Muscular Dystrophy Certified Care Center. Dr. Kwan.
Thank you. I'm Jennifer Kwan, and I'm happy to speak as the organizational representative for the Child Neurology Society to the advisory committee. Next slide. I am at the University of Wisconsin, and my only disclosure is that I'm the site PI for Novartis, formerly Avexis sponsored clinical trials in gene therapy for spinal muscular atrophy. Next slide. I'll be talking about the Child Neurology Society, briefly introducing our society, as well as who we are as child neurologists and how we've grown. Despite our growth, we still have a number of workforce challenges, primarily to keep up with the new discoveries in the field and the new treatments. We do need more child neurologists, as well as child neurology subspecialists, including neuromuscular subspecialists and those who specialize in other degenerative conditions, such as inherited white matter disorders. The Child Neurology Society in the past year and a half has come up with some innovative solution to addressing the challenges that we faced as a profession. So I'll briefly talk about our COVID response and telehealth guidance, as well as ways we have of trying to increase recruitment over time. Next slide, please. So the National Office of the Child Neurology Society is based in St. Paul, Minnesota, and our executive director is Roger Larson. Our current president is Dr. Phil Pearl. The Child Neurology Society was founded in 1972, and it had an initial enrollment of about 200 members. Today, the membership is over 2,000, and it exists to serve academic, research, and practice-based needs of child neurologists. So who are child neurologists? Next slide, please. So after medical school, child neurologists undergo a 5-year postgraduate residency. Historically, child neurologists were actually adult neurologists who had a particular interest in neurologic conditions presenting in children. Our training reflects that background. So we have 2 years of training in pediatrics, a year of adult neurology training, as well as 2 years dedicated to pediatric neurology. Many of us go on to additional subspecialty training after that, either in epilepsy, neurophysiology, or neuromuscular disorders. Because of our year training in adult neurology, many of us are also see adults actually in practice or continue to follow our pediatric patients into their adult years. Today, there are over 70 university-based child neurology training programs enrolling over 150 candidates yearly in the US and Canada. That's an increase from 2000, so over the past 20 years, when there were only 58 programs and approximately 80 positions. So that is one. We've had workforce concerns since the late 90s, and this was one way of responding to those concerns. Also, it's helped that we are part of the MATCH program. Next slide, please. I really enjoyed Dr. Blitzer's numbers from the board. I don't have those similar numbers available to me, but just based on Child Neurology Society membership, obviously our numbers have grown. So basically, as I said, we now have over 2,000 members, and you can see how that's increased over time. Unfortunately, that it's still not enough to meet the demand that we have right now, and that's not even including newborn screening. So next slide, please. The reason for that demand is really just the dramatic increase we've seen in medical knowledge, including information about genetic mechanisms and how that leads to novel treatments. More and more of us are seeing the need for subspecialty training because standards of care for some of these rare conditions, so I'll give you an example, like infantile spasms, or even some of the disorders that we see in newborn screening, such as ALD, they have standards of care that we feel in order to really implement require a higher level of training than we received in our general child neurology training. So having that additional specialized experience can be helpful. Even community-based general child neurologists find themselves increasingly facing rare conditions for which they need to keep up with this new knowledge. And again, having access to specialized centers is helpful for our community-based colleagues. So because of the complexity of our patients, we find that we routinely engage with other specialists and services. We care for our patients in a multidisciplinary world filled with therapists, geneticists, genetic counselors, and more. And that also impacts what we're able to do and how we're able to provide services. So all of these things put a lot of pressure on our field. Next slide, please. So as I said, we need more child neurologists to keep up with these innovations and the heightened expectations that we have. We also have an aging workforce that we need to replace. even though the number of training opportunities has increased, really we haven't seen much of an increase in terms of interest. So even though we have twice as many people applying for available residency slots, the overall number of residency applicants has not really changed over the years. So we do need to think of ways to improve recruitment of new trainees. Part of the issue that we face is that compensation has not been good as it has been for adult neurologists. Child neurologists, we sort of span that area between loving the brain and loving neurology, and also always wanting to experience the joy of working with children. And so part of the cost of that is that our discipline takes a lot of time and we're not paid at the same rate as our adult neurology counterparts. We do tend to work in large urban areas, and I actually think that pressure is going to increase as our knowledge, as our patients become more specialized and we know more about genetic mechanisms and ways of intervening with care. Child neurologists feel more compelled to be at centers that have the kind of imaging services and neurodiagnostic services that they need to be able to provide good care. So we tend to cluster in more urban areas, and that is certainly a stress on our patients because they need to travel longer distances to see us. We've tried to work out different ways of addressing that. Next slide, please. So on the top right is the fact that since COVID, we've been using more multidisciplinary telehealth services. But I would say that over the past 10 years, child neurologists have really seen the need for telehealth expansion. There just have been a number of barriers. The one positive about COVID that was brought up at yesterday's session, I think Michelle Kajana was the first one who mentioned it, but other people also chimed in to say that the increasing use of telehealth has been a real benefit of the COVID pandemic. And I would say that we've experienced it as well. Many of the state-based barriers and insurance-based barriers to telehealth disappeared under the emergency acts of COVID, and we were able to see patients much more readily without having to force them to travel to see us. And so that's been a real benefit. And unfortunately, we're seeing that disappear as states no longer are bound by emergency procedures and are not really allowing telehealth services, for example, across state lines. That's been a real problem. What we did also do during COVID is that when patients would come to see us for their in-person visits, we tried harder to increase our care coordination for those patients. So if I knew that a patient had to come in for an NJ tube change, for example, we would try to add on some surveillance laboratory testing and other visits during those in-person trips by families. Again, that increase in care coordination is a burden that child neurologists take on. We especially took that on in the neuromuscular program for our patients who had been identified by newborn screening, let's say with SMA, who needed to come in for visits for lab work. The other response that child neurologists across the country are implementing, those of us who are in larger centers in more urban areas, do try to travel ourselves to outreach clinics to see patients in more distant parts of our states. So during the COVID times, especially, the Child Neurology Society came up with a number of statements and practice guidelines to help child neurology members. So that included an ethics statement about accessibility to services during the COVID-19 era. We had a change in practice parameters for infantile spasms to allow families and providers alternative ways of treatment at a time when it was harder to see patients in person. There were guidances about how to conduct teleneurology examinations. And I will say that one of the positives of telehealth visits is that it's often a much more comfortable visit for children. As you can imagine, they're playing in their home and you can see much more active engagement, sometimes doing home visits that way. There was also guidance from the Child Neurology Society about reopening practices and how to safely do that, as well as a statement on institutional racism, which is an obvious public health concern. Child neurologists, because of the conditions that we treat, do depend on our society to help us understand the best care practices, how to safely care for children who have rare conditions. And so we benefited from the SMA newborn screening guidelines that were sponsored by QRSMA, but included the input of many child neurologists. The X-linked adrenoleukodystrophy guidelines likewise have been a great help in terms of following children with XALD. And I look forward to looking at the guidance and patient information that Kate Bockley had noted in her talk. Next slide, please. So SMA was added to the RUSP in 2018, and this map shows the number of states that have adopted screening for SMA. This 36 as of last month when I looked at the map, and that's about 70% of newborns in the US who are being screened for SMA. And the reason I bring that up, next slide please, is because of course SMA newborn screening has really, I think, really brought child neurologists into the fold of newborn screening, short and long-term follow-up care. So we are the primary specialists who see infants identified by state newborn screening programs. Before there was newborn screening for SMA, we were the ones who led efforts to define natural history studies that could be used in the clinical trials that help develop the novel treatments that are available for spinal muscular atrophy. We really have, I mean, I think that it's hard to express how overwhelming it has been to see the benefits of newborn screening in this population. So I would say that one of the new things that we'll have to do, so short-term follow-up for SMA has involved a fair amount of, just scrambling to identify the appropriate treatment and to institute them early. And you may wonder what long-term follow-up needs there are, but I think that in the 2018 meeting, before it was approved on the RUSP, there were a number of concerns that were raised about these highly efficacious treatments, but the fact that we hadn't really been following these treatments for very long. They'd only been, we were only seeing the data over a few years, and how do we know about how long and how durable these treatments are? So I think most child neurologists are committed to following these patients who are referred soon after newborn screening. We're committed to following them for years in terms of understanding the natural history of SMA that's being treated or that has been treated in the pre-symptomatic stage. So we have always recognized the importance of multi-center collaborations, and I should also say the importance of multidisciplinary collaborations. While SMA is a particular disorder that I think most child neurologists are fairly comfortable with, the other disorders that we're going to be involved with that are identified by newborn screening are ones where we would certainly need multidisciplinary help. I think Kate Bockley brought up the comment about patients in waiting in her talk. And I was just thinking about how that really applies to children who are identified with late onset Pompe disease and with adrenoleukodystrophy. I think they feel like they're waiting for the other shoe to drop. And how do we, in terms of being child neurologists and wanting to follow their neurologic status, how do we bring in the other disciplines who are also needed to care for these patients and to answer these families' questions? So while we've been energized by the benefits of SMA newborn screening, we do have a lot of questions that we have about how, what our role is and how to make the most of our role with these other newborn screening programs. So this was really a fairly brief talk. Next slide. To introduce you to who we are as child neurologists and what we want to do to help with future newborn screening program efforts. I want to thank Margie Ream, who is a child neurologist at Nationwide Children's Hospital. She's been involved with the evidence review group. And I think that the involvement of child neurologists in the evidence review group, as well as on this committee, will be very important as new disorders are being introduced to the committee. I also wanted to thank my colleague, Adam Wallace, a child neurologist here at the University of Wisconsin, who has also thought a lot about workforce issues and how to improve that. And really the key is to improving medical school enrollment overall in our high school and undergraduates, and then improving the exposure of neurology to our medical students. My last slide was just a slide about questions, but I'll wait till the end. Thank you very much for your time.
Thank you, Dr. Kwan. Next, we will hear from Dr. Julie Cantor and Dr. Marcia Treadwell, who are both principal investigators for the HRSA-funded Sickle Cell Disease Treatment Demonstration Program. Dr. Julie Cantor, currently at the University of Alabama at Birmingham, is a lifespan hematologist specializing in sickle cell disease. She works closely with a variety of national partners on advocacy and research, as well as industry and federal partners to develop new treatments for sickle cell disease. She has specific interests in gene therapy, anti-adhesion therapy, and novel combination therapy. Dr. Cantor has received NHLBI funding in dissemination and implementation to improve access to care for affected individuals. She has authored and co-authored more than 100 articles, book chapters, and abstracts. Dr. Treadwell is a professor of pediatrics in the Division of Hematology at the University of California, San Francisco. She is the Jordan Fund Endowed Chair in the Department of Hematology Oncology at UCSF Benhoff Children's Hospital, Oakland. Dr. Treadwell is co-PI and regional director for the HRSA-funded Pacific Sickle Cell Regional Collaborative that focuses on improving access to sickle cell disease care in 13 Western states. She is co-PI and director for the Sickle Cell Care Coordination Initiative, funded as a Sickle Cell Disease Implementation Consortium project by the National Heart, Lung, and Blood Institute. Dr. Treadwell is recognized internationally as an expert in the transition from pediatric to adult care, quality of life, patient-reported outcomes, and community engagement. Dr. Cantor, I will now turn it over to you.
Thank you very much, and thank you for having both of us today. I would be lying if I said that these efforts were just mine and Dr. Treadwell's alone. In fact, we represent 2 regions of the HRSA Sickle Cell Disease Treatment Demonstration Project. And all of these efforts have really been done in collaboration with our national groups, all our national PIs. So we're going to talk about increasing access to expertise in sickle cell disease care by training of advanced practice providers. Next slide. These are our disclosures, which really aren't relevant. Next slide. So the goal, it seems in many genetic diseases, is too many patients, not enough experts to really help manage the care of these individuals. And this is especially true in adults living with sickle cell disease care. And in fact, many adults are receiving care in settings that don't have appropriate resources. I could tell you stories that are amazing of 40-year-old patients who've never seen a sickle cell specialist, of 23-year-old patients who once saw a sickle cell specialist when they were 1 or what they remember as 1, and then haven't seen one since. And so the goal all along has been, how do we improve access to care? And in previous sickle cell disease treatment demonstration projects, This was thought to be through primary care providers. If we could further educate primary care doctors in managing sickle cell disease, that would increase the number of physicians who had expertise to provide this care. However, despite multiple years of effort, we've really recognized that there's a concerted lack of interest. Now, primary care doctors are heroes in our field of medicine. They are managing every condition out there, and they don't often have the time to dedicate to learning enough about sickle cell disease, a multi-system disorder, to provide this kind of expert care. There's lack of interest due to lack of time, and there's clearly insufficient reimbursement. There's also insufficient support systems for primary care doctors, social workers, case managers, and other necessary personnel. So we attempted a new solution during this last sickle cell disease treatment demonstration project grant. It was called the STAMP Initiative, the Sickle Cell Disease Training and Mentoring Program for Primary Care Providers. And it was a joint project of the grantees and the Office of Minority Health. And OMH recruited primary care providers from everywhere, multiple societies, centers, et cetera. They really said to us, we don't believe you guys have tried hard enough to recruit these primary care doctors. We're going to try for you. And well over 1,000 individuals were recruited. In my state alone, it was over 300 individuals. And our part of this, the regional grantees, were to hold ECHO education and mentoring sessions designed for primary care doctors. The good news is STAMP was well attended, but it was really a variety of healthcare workers and community members. It was very few primary care doctors. Very few primary care doctors who did attend didn't reach out and attend more than one session. And actually none of them followed up with an ongoing interest to manage or take on the care of patients with sickle cell disease. So obviously we said, okay, we have to find another way. So we regionally, all of the PIs have gotten together, and we collectively believe it's appropriate to shift capacity to building advanced practice providers who can be trained to work as extensions of sickle cell specialists. Next slide. So from there was born the support program, the Sickle Cell Disease Advanced Practice Providers Opportunities, Resources, and Training Program, known as support because it's way too hard to say all of that at once. And this is a collective program that really is run by all of us. So Marcia and I are representatives of a greater good who are really doing a lot of this work. And that's especially the Synergy region, Northeast, run by Dr. Sophie Landskron. And there are three main components of this program. So first, there's an APP-focused ECHO. This is an ECHO that's recurring telementoring session, and it's specifically geared for APPs. In fact, it's run by and sponsored by advanced practice providers with physicians just lurking in the background in case they're needed. It's case-based learning and mentoring sessions with brief didactics on specific areas of sickle cell care, and again, fully facilitated by APPs. As many of us already have specialized APPs in our clinic, they are really the best ones to teach other peers. And they're open to all APPs regardless of their expertise in sickle cell disease care or the participation in this second component. The second component is a web-based online curriculum. This is a special learning management platform that we have developed to specifically allow for asynchronous education of APPs in sickle cell disease care. And this is a series of, as you might imagine, curriculum where they have pre and post tests. And if they complete everything in addition to their ECHO attendance and the following observership, they actually will get a certificate. So the observership is at Sickle Cell Disease Centers of Excellence. And these are times that APPs can come and observe and really get additional training in quality evidence-based care for sickle cell disease. So what we've done is all of our treatment demonstration project grantees have identified and referred APPs to participate in support. We've all worked together to formulate and provide the curriculum content, provide the observership opportunities, and then to collectively pay for this as well out of our treatment demonstration grants and OMH supplements. Next slide. So what are the goals? To increase access to quality evidence-informed sickle cell disease care. We know that we need more providers, and we are partnering with APPs to do this. So partner with site leads in specific states to train APPs and then embed those APPs in primary or secondary settings. So that may be, for example, that we have more APPs within our sickle cell disease centers so that we can increase the number of patients that we manage. But it may be, as I did in South Carolina, that I have an APP in an entirely separate area of South Carolina who really runs the day-to-day clinic of a small clinic with sickle cell disease patients, and that I am there constantly if she needs me or to help manage those patients and to provide opioid prescriptions. Or it could be that an APP works in primary care, but agrees to take on a significant number of individuals living with sickle cell disease. We're including these echo sessions that are tailored for APPs. We're increasing the accessibility to specialists for on-demand consultation, and then facilitating additional co-management so that we can really get hands-on and improve the care for our patients. We're doing measurement in many different ways. We're measuring the number and type of participants in the echoes and other trainings, the number of individuals with sickle cell disease served, and then looking at other things such as hydroxyurea prescriptions, pediatrics who have completed transcranial Doppler or stroke screening, and are they getting the right immunizations? Next slide. So this is our logo, our support logo. Again, it's a one-year program, and the participant is required to attend the echoes, complete the curriculum, and an observership. There's many modules that make up this curriculum that includes benign hematology, pain management, which you can imagine we do quite a lot of, especially in adults with sickle cell disease, but also with children. Identifying, recognizing, and treating acute sickle cell disease complication, understanding the use of disease-modifying and curative therapies, and ensuring that we are appropriately evaluating and helping those with specific issues with social determinants of health. As discussed previously, there's also modules on implicit bias and addressing systemic racism. Next slide. So this is just our Echo flyer. This shows you what we're doing and how our goals are really to make hub and spokes using our support Echo series. And we've had excellent attendance, so we're very excited about that. Next slide. And with this, I'm going to turn it over to Dr. Treadwell. Thank you very much.
Thank you so much, and thank you to the organizers for having both of us. As Julie mentioned, we definitely are part of a big collaborative that's national. We represent 2 of the regions, but there are 5 regions for the Sickle Cell Disease Treatment Demonstration Program. So I'm just going to talk a little bit about our evaluation, which has really just begun. We're really working with a supplement right now. And so with that, the regional collaborative, the 5 regions are, as Julie mentioned, we are looking at these advanced practice providers, and how we're going to evaluate that is their assessment of their sickle cell disease knowledge based on existing guidelines and their confidence in their knowledge of sickle cell disease. Within the Pacific Sickle Cell Regional Collaborative, we're also using some implementation science strategies to evaluate this program. So I can talk a little bit more about that. We have 2 APPs in the Pacific region. We have 2 hematologists who are mentoring them. And the mentors completed a practice change readiness assessment measure. And then our study coordinator here interviewed both mentors and the advanced practice providers, the 2 advanced practice providers, to find out what they feel is needed to best support their training, what will be needed to extend this training beyond this supplemental pilot, and anticipated challenges as well as other thoughts. Next slide. So the 2 sites in the Pacific region, one is pediatric and one is adult. With the pediatric site, the hematologist and the advanced practice provider are at different hospitals. The mentor's practice size is about 40 patients with sickle cell disease per month. They're just getting started together over the last few months, so they haven't really co-managed patients yet. Where we're starting in terms of our metrics is that the hydroxyurea adherence is quite high, as is the adherence with the transcranial Doppler screening. Site 2 is an adult site, so the APP is actually in a primary care clinic that serves sickle cell disease. The mentor's practice size is about 15 a month, so a bit smaller than the pediatric site. The mentor and APP are currently co-managing, so they came into the project co-managing people with sickle cell disease with the hydroxyurea adherence and immunizations not quite as high. Next slide. So when we asked in terms of baseline readiness,
The pediatric site really focused on in thinking about how ready they are to implement the advanced practice training, that this training really fit in with their organization's strategies towards innovation. It's aligned with the institution's priorities, and they really feel that their ability to observe results is going to really help move the project forward. They also felt very strongly that there is a program champion within their organization, good relationships, the ability to use evidence-informed care. And the areas to improve might be there's not really a system in place to monitor how well the practice changes end up being implemented. They're concerned about a return to the previous way of administering care, and that the priority in terms of sickle cell may not be as high as it should be. Next slide. For Site 2, similar ratings in terms of that this is an innovative program, and so that's attractive to the larger institution. And again, it aligns with the larger institution's goals. They do have a champion, again, very similar to the pediatric site in the remaining strong ratings of readiness as well as the weaker ratings. Next slide. So in doing our qualitative interviews, areas of consensus between the mentors and the mentees across the two sites, they all felt that the APP project was a very important strategy for increasing access to quality evidence-informed care for people with sickle cell disease, with a representative quote that prior to this, so many things were falling through the cracks. They did have some concerns about communication within and between health systems across the two sites and across the mentors and mentees, that there's a need for broader staff education about sickle cell disease, not just having it lie on the APP and the mentor. It's important for the mentor and the APP to have a very collegial relationship with easy and open communication, that this funding support of the supplement is allowing this project to unfold. And what would program success look like to be able to intelligently and confidently speak about sickle cell disease versus having a superficial knowledge. Next slide. Site differences. In one of the sites, the APP, again, is dedicated to the sickle cell population. In the other, they have other duties. In the pediatric site, the relationship between the mentor and APTP is new, whereas in the adult site, it was already established. It was mentioned in another presentation here that access to a social worker is so important for genetic conditions, sickle cell disease no less, and that access is limited. And at one of the sites, it was limited. And then at one of the sites as well, there was some concern expressed that other providers might feel that the APP was actually taking their patients away. Next slide. So across both sites, as Julie mentioned, pain is so important in sickle cell disease, and the adult site actually has already a focus on implementing individualized pain plans. So we will likely look to adding pain management itself as a quality indicator. We really need to include the voice of individuals with sickle cell disease participating in this APP supplement and find out what they think about the quality of and access to care. We have an additional supplement to expand telehealth, and that's being integrated with this APP supplement. We want to expand the sickle cell education for the APPs across, again, the state, the region, and the nation, and provide specific education about structural racism and its impact on sickle cell disease, as well as incorporate a focus on social determinants of health. Next slide. And I think that's it. Thank you so much.
Thank you very much, Dr. Treadwell and Dr. Cantor. We'll now have an opportunity for discussion, questions and comments. As usual, we'll open it up to our committee members first, followed by organizational representatives. And please remember to state your first and last names and make sure your mics are open. let's see. So Scott Schoen.
I didn't have my hand up, but I'm happy to make a comment.
Oh, okay. I'm sorry. I thought I saw your hand.
No, you were reading my mind, Dr. Powell. I just want to just say real quick then, while I have the mic, that great presentations, and clearly, especially on the geneticist and genetic counselor's perspective, real clear need as we're moving forward with these disorders to expand that workforce. And I think it's interesting juxtaposed next to some of the public comment on the need for the committee to get ahead of new therapies and move expeditiously to add conditions to newborn screening, and further reinforces a constant drumbeat that we've had at the committee meetings over the past at least years that I've been on the committee, across the different topics we've talked about, whether it's workforce, education, continuity of operations, that this is a system, and the programs alone that are being encouraged to expand, lab testing and follow-up, have to rely on a system that is dependent upon the workforce shortages we just heard about, and so many other things. And so I would encourage and look to partner with those who want to continue to expand at an exponential rate, that we work beyond just the newborn screening programs, but as a system to look at the genetic counselors, the geneticists, and everything else that we need to make the system function, to expand those as well. Because, Dr. Kwan's presentation on neurology, I mean, just there's so much that has to grow beyond just the tests and getting babies to care to make this work, to assure that we are finding and appropriately treating quickly. Thanks.
May Baker.
Sorry, take time for me to unmute. May Baker, committee member. My question is for Dr. Trenberg-Well, and maybe it's I don't know. I wouldn't think this in the future, because giving such a promising for gene therapy for sickle cell disease, so how this training and education go hand by hand? Because I almost think our newborn screening, the education material, have to start to think about this aspect, because the equity, accessibility. So could you make some comments on that?
Well, I actually will defer first to Dr. Cantor, and then I'll speak on it.
Sure. So I think gene therapy is very promising, but I think we have a very long way to go before it's going to be universally available. I do think there's the potential for that, but we don't even know the optimal gene therapy. There's some significant barriers that we've recently come across that hopefully we won't see again with the advent of leukemia as into sort of failed gene therapy. But I do think it's important in general in newborn screening to impart so much more hope. I have many individuals living into their 60s and 70s with hydroxyurea and our newer therapies that are available, not just gene therapy, but crizanlizumab and Oxbryta and other ones coming down the pipeline, and our increased use of exchange transfusions, and then stem cell transplant itself. So I think we have incredibly diverse new therapies, and more are coming. So I hope that helps answer, but I think gene therapy is going to be another 5 to 10 years before we get too far.
Yeah, exactly. And what I would just add is that in sickle cell disease, there has been limited focus on really the disease modifying and curative therapies until recently. And the quality of life of people has really been neglected. And so this increase in workforce, I think, can address that while we were in the midst of beginning to roll out these disease modifying therapies and curative therapies. It's really important in terms of the quality of life. And our APP, who's the adult provider working on the pain management, that's a huge focus. And again, it'll be a while before people are going to not be having those issues with pain. Thanks for the question.
Yes.
Melissa Parisi.
Thank you. Melissa Precy from NIH. My question is one that's a little bit more generic, and I'm raising this for anyone to answer if they know. But I think all of us would agree that one of the silver linings from this pandemic has been the increase in telehealth and telemedicine services being made available to families. And Dr. Kwan, I was a little distressed to hear that reports are that states are now reverting back to previous restrictions on allowing cross-state provisions of care for providers who may not be licensed in a given state. I guess I'm wondering if, given the, I would say, overwhelming support for continuing in this mode, if at all possible, if there's any legislation, federal legislation, or activities that any groups are pursuing that might actually try to establish standards nationwide for provision of telehealth services.
Dr. Kwan, do you want to respond?
I'm not aware of any because it is complicated with the states. I think that the American Academy of Neurology and the Child Neurology Society, and probably any other society that has benefited from interstate telehealth, would agree that we need some relaxation of these restrictions. But I think it's difficult for national entities to make these sort of state-based like recommendations, but I will certainly, it's one of my pieces of homework to go back to the CNS and AAN to ask them what they're doing in this regard, because we're definitely feeling it. I have families who drive across the border just to be in Wisconsin so that I can see them. So we're doing a telehealth visit from their car, basically. And that's better than nothing, but it does feel a little silly.
Kate, did you want to respond to that?
Yeah, I just wanted to second what Dr. Kwan said, that it really becomes an issue of states. I actually just yesterday got an email from the Pennsylvania Licensing Board saying that they were going to be discontinuing the waivers that were put in place when COVID was impacted the system. So it really is a state licensure issue, and I don't know how much influence the federal legislation might have on something like that. So we may have to go back to the old way of state by state.
Joan Scott, did you have a comment?
Yeah, thank you. I was just going to offer up potentially the services or information. HRSA runs the telehealth resource centers, and there is one that does address national policy and issues, and we can certainly have them report at an upcoming meeting if the advisory committee is interested on trends and activities that are happening in this area.
Thank you. Okay, Robert Ostrander.
Yeah, hi, Robert Ostrander, AAFP. I spend a lot of time in the adult world as well, and I think this what happens in the adult world can inform some of our discussions. I got into this whole universe 20-some years ago when our practice was part of a national learning collaborative on medical home with NICU for children and youth with special health care needs. And it was striking in that collaborative, it was about 2/3 pediatricians and 1/3 family physicians, how different in some ways our approach to people with chronic conditions was, because we have a lot of adults with complex chronic conditions. And I think there may be some lessons learned when we're trying to address some of these workforce issues in looking at how the adult primary care world deals with super complicated patients. And both through evolution and intent of a reasonably highly functioning primary care medical home, a lot of us are pretty good at handling adults with very complex conditions. And I think maybe some of that model could be considered as you look as to how to get workforce help from the primary care world as members of the medical home. One of the challenges, though, and one of the differences is that a lot of our folks with complex conditions are reasonably common. So we have some experience, and we also have connection with our subspecialists that we're working with. It becomes a little more muddy, whether it's adults or kids, when it's a complex rare disease. But I still think that that's something that should be looked at when folks are exploring potential ways to stretch the workforce of subspecialists and geneticists for that matter. I'm not at all surprised that they couldn't get interest with Project ECHO for PCPs because, I get several a year, I get an email or an invitation to be, to join a 6 or 10 session Project ECHO for some specialized disease that everybody thinks primary doctors should know more about. So I agree with that. I'm glad you tested that model, but I'm not surprised it didn't work. And I think it's good knowing that going forward. And to phrase this in form of a question, I just wonder, across the group, and especially, maybe Dr. Kwan, partly because she and I have worked together, but when she was back in Western New York, had any thoughts about a model that involves the primary care physician in a way that allows some of the work to be shifted to the primary care physician without making the primary care physician the center of that specific disease's management.
Dr. Kwan, do you want to comment?
Well, what I would say is that I think that one of the things I thought was so interesting and inspiring from Dr. Cantor's and Treadwell's presentation was that it was a reminder of how disease specific these issues are. I mean, what a beautiful reminder of the lifelong chronic multi-system difficulties of caring for this particular disorder, and how hard it has been and how challenging it has been to wrap our arms around it, to move it forward. And in many ways, we have to recreate that for every one of these rare conditions that we face, some of them to a lesser degree than others. And so I would say that I am pretty bad at figuring out ways of involving primary care physicians, partly because the diseases that I sit in a silo with tend to be they just tend to be more specialized, but I do see that changing. For example, I do think that for some conditions like X-linked adrenoleukodystrophy and late onset Pompe disease, I think their follow-up, I have seen how an engaged primary care physician can really make a big difference in terms of compliance and patient satisfaction and quality of life with those disorders. So I have to think more about it myself.
This is Julie, and I just wanted to tell you, we have worked with medical homes as well. It wasn't just isolated primary care physicians. The global STAMP project was everyone. If there were a primary care provider in the state, and it wasn't just that they were invited to ECHO, they were actually given our phone numbers and email addresses if they had a concern or problem or consultation for sickle cell disease. I was terrified we were going to get inundated. I can't tell you how disappointed I was to not get any calls. And I've also worked directly with medical homes where the patients ended up actually leaving the medical home in order to come into our center where they could get more specific care. However, what we have done and what I actually think has been incredibly useful, and I did this in South Carolina and in Alabama, we actually have a primary care provider in my sickle cell center. And that's what has been done in many other places as well, Ohio State, Atrium Health, just to name a few. And we have seen incredible satisfaction from patients. We're actually now hiring a psychologist as well, because patients have lives too. And so they don't want to have to go to their sickle cell specialist and their primary care doctor and their psychologist when they're trying to work and maintain a family. So we call it the one-stop shopping model. And it's not going to be feasible for everyone, but the amount of increase in primary care complications and needs addressed has just tripled. So I think that the medical home model is fantastic, but I like it as a specialty medical home model in some of these very complicated patients.
Jed Miller.
Yes, hi, Jed Miller, Association of Maternal and Child Health Programs. And I was going to say that I'm going to ask the converse of what Dr. Ostrander was asking, but then Dr. Cantor, what you said is going in this direction is, I'm curious about panelists' experience where, because of family preferences, they desire the specialist to be the medical home. I know you just mentioned about, Dr. Cantor, about, subspecialist medical home. And I'm wondering that especially for Dr. Blitzer, but not only for you with respect to the combined residency in pediatrics and medical genetics. I'm not sure if you capture any data about how providers' practices actually look. Because in that scenario, they'd be armed to be the, they could provide well child visits as well as do the specialty care. And I'm just curious if there's any experiences on that front, in terms of functioning as a medical home with or without the routine health maintenance measures such as immunizations. And so on a somewhat related note, Dr. Kwan, you were talking about seeing children in longer than you might otherwise into early adulthood, and I'm wondering if there's any experiences with that life course and actually caring for caring across generations, meaning if you see children long enough, perhaps they will become parents themselves. And just thinking about even parenthood itself could be thought of as a long-term follow-up measure of sorts, or an outcome in certain ways. So just curious if any panelists have any comments on those topics.
Mimi, do you want to take that first?
Or I'll start briefly. And thank you, Dr. Miller. From the standpoint of individuals who are certified or trained and then are ultimately certified in 2 specialties, and let's concentrate, the majority of those would be peds and medical genetics and genomics. We do, and I'm going to let Dr. Powell comment afterwards, as this is her area as well. We do see, since geneticists do see patients across ages, there's not the pediatric restriction on them, that metabolic patients many times continue with their geneticist, who may also be a pediatrician, but really as a geneticist managing their care. And in many situations, at many institutions, it does become their primary care home, their medical home to some extent. The board in and of itself does not do practice surveys. Our college does, and also in the workforce study, we did get that feedback as well. So I would say, in general, we do see people going into the combined, and those that are interested in metabolic, certainly managing patients as they transition from pediatrics to adulthood in their own families. I wanted to also mention that we had this relatively new specialty. The first exam was given in 2009 of a subspecialty in medical biochemical genetics. It is a group that is growing. Again, the numbers are small because it's a new specialty or subspecialty, but it's clearly the area of growth where most individuals who are completing, or many of the individuals who are completing their residency and training in medical genetics or in the combined, are also training in this subspecialty, with an almost doubling from 2017 to 2019 in the number of individuals certified and moving forward. So I do think the answer is that the medical home would be there for those groups. Dr. Powell?
Yeah, I agree. I think, we are training a number of individuals now in who have a background in internal medicine, which has really been very helpful to help as our patients with rare disorders transition to adulthood, because it's been extremely difficult to find providers willing to take care of them in any area, even specialty care. And I'll turn it over to Dr. Kwan.
Thanks. I think this is where it's helpful to remember that I work as part of a team. And so in many places, in many medical centers, it is difficult for a primarily pediatric provider to see patients easily into their adult years. Emergency rooms, so I think it requires me to become familiar with the adult medical care system, which can be challenging for a variety of reasons. And, so as soon as my patients get to that 18 to 21 year transition period, I will say that at this point, I tend to try to transition them to adult neuromuscular providers, primarily for all kinds of practical reasons. Even the nurse practitioners that many of us work with may only be licensed to take care of patients who are pediatric patients. So that I think that there's sort of this ripple effect, like who will the emergency room see? Where will they be admitted? And having the adult age makes it challenging. But I think that it's an important thing to think about who is the, sometimes I'm not sure what a medical home is. And I feel like that's a term that's used less in Wisconsin than it was in New York when I lived there. But I think that patients who have rare disorders identified by newborn screening, who have chronic diseases that require a lifetime of care, need a medical network. They need a medical support system that we have to help identify and help maintain through their life cycle. And I will say that, for example, with SMA, I follow a number of patients into their adult years, and it is fascinating how many of them want to be parents and are making decisions about treatment based on that. But I do think that the system unfortunately feels very fragmented and broken right now, and doesn't make it easy for us to create those lifetime networks for patients with chronic diseases.
In order of those who I've seen with their hands raised, first we'll take Natasha, then Sean, then Georgianne, and Deborah. You'll be after Georgianne. Natasha?
Great, thank you so much, Natasha Bonham, Genetic Alliance. I have kind of a two-part question, mostly for our first two speakers. So I wonder if you could speak a bit to what the vision is for the growth of the workforce in genetics. Are we looking at hoping for 15 to 20% above what we currently have, or is it measuring the length of time that someone has to wait to go and see a genetics service provider and reducing that to X number of days? Just trying to get a better sense of what would success look like, not necessarily just for today, but where we're projected to go, knowing that there are projections around gene therapy and all other parts of the system. And then also my kind of part two or second question is, it was really interesting to see the growth of genetic counseling programs as well as the growth of student enrollment, and just wanting to get a better sense of, is the growth in diversity equal to that, more, less, just kind of putting that into context, knowing that particularly in the past year, there's been a number of different work groups and initiatives really looking at that issue. Thank you.
Mimi?
Sure. Thank you, Natasha. Those are excellent questions and topics that we're thinking about very seriously. The question of growth, and that's what we're looking at now, is first understanding what has the growth been and do we see growth, and then also understanding how many clinical geneticists, laboratory and other of the workforce working with genetic counselors and dietitians and other providers, nurse practitioners, do we need? From the standpoint of ABMGG, and we really are looking with our college, with the college on this, since we are the certifying arm, is that we would really hope that we begin to see what my personal thoughts would be a significant increase of 10 to 15%, but looking at it consistently to see a slope begin to go up. To that end, I wanted to touch base on your second topic. We are a relatively new specialty, although it sounds like we're pretty old at 30 or 40 years, but we are relatively new. And to recruit into our specialty, and let me just only talk about clinical geneticists recruiting from med school. We have to be on the forefront. So when medical students get into their third or fourth year of training, there isn't a requirement that they do a medical genetics rotation, for instance. And sometimes the goal is how do we get them as excited and recognize what this field is all about and what the promises are. I do think the combined residencies have helped. I do think that a better reimbursement for clinical geneticists will help. We're not there. From the standpoint of diversity, that's a huge issue, not just in our specialty, but it's one that we're focusing on. And one of the things we're doing is definitely, as I mentioned before, right now we're in the midst of trying to look at what's the pipeline look like compared to clinical geneticists and medical geneticists that are already in practice. We are actually a relatively young specialty as far as looking at the age of our diplomates, but we need to look at this. We have a task force working on this, and one of the things is that we still have open slots, open positions for residents in certain programs. And so one opportunity there is, how do we not only attract medical students, but underrepresented minority medical students into our specialty and have them recognize the field? For instance, out of the 4 HBCU medical schools, there's not one board certified clinical geneticist at any of those 4. So there's not really good role modeling or exposure. And how do we partner and do this? To that end, I'm working with the dean at one of the HBCUs on how to increase exposure and excitement to our field, and recognizing how important it is that they be an incredibly competitive group to come into our field, and we need them. So I'm going to stop there. Thank you.
Sean Dolan.
Good afternoon. Thank you so much for this extremely interesting set of discussions this afternoon. My question is for Kate Walsh-Foxley. And Kate, I was wondering if you have any thoughts or comments on the role of genetic counseling assistant as a way to flesh out and expand the genetic counseling, or sort of, that's actually the question. Do you see a role? Where does that work well? How could that fit in a genetic counseling assistant role around this newborn screening and increasing genetic counseling capacity?
We have been using genetic counselors in general genetics clinic, not so much in the newborn screening setting at this point, although I do believe that that is one way that we could increase capacity with having, here in Pittsburgh, our genetic counselors are really helpful with some of the coordination of appointments, with coordination of testing, reaching out to family members to get samples, a lot of the nuts and bolts of getting things done. And I do think that that is one area where we have been able to utilize non-genetic counseling trained individuals. I mean, they do have to go through a period of training themselves, but oftentimes it's within the clinic setting that they're trained. I know some of the programs do have a 1-year genetic counseling assistant training program as well. And I do think that that's been a big help and could be applied in newborn screening as well. Relative to the previous comments in terms of growth of the profession, genetic counseling training doesn't exist in a vacuum. We are bound by available clinical training sites and the requirements of the accreditation and board in terms of moving forward with more programs. I think the anticipation is that we will continue to grow. I think the growth rate has been so significant in the last 5 years that it will be hard to keep up that growth rate. But I think there are a lot of people interested in doing that. And as far as the diversity question, I know looking at our programs, incoming students, there's been a tremendous effort to increase diversity in the programs. The program directors organization has been making efforts in that regard. And I do think that our program, at least a third of the students are considered underrepresented, maybe closer to a half. So I think it's doable. I think we can reach out to the communities and increase diversity in our field.
Thank you. Sean McCandless, did you?
Thank you.
this conversation is both enlightening and very frustrating. I've been just writing down lists of notes of things to discuss. I think I have a lot of questions about, number one, what is the role of this committee in thinking about this issue? I mean, I understand this is more for informational and brainstorming, but these workforce issues are incredibly complex. And some of the thoughts that I've had are, first off, is there really a shortage? Are there shortages, and who determines the workforce need? And I think if you look at the NSGC website, they have the National Society for Genetic Counselors states explicitly that there is not a shortage of genetic counselors. And they have pretty good information to support that on the website. For physicians, I think but with that said, there's clearly a deficiency in certain areas in the US. And the same is true for physicians. There are genetics clinics for physicians in the US where you can be seen with very little wait. And there are other places where you have to drive hundreds of miles and still have a 6 to 12 month wait to be seen. So it's not so much, it's a shortage maybe, but it's also a distribution issue. All of the problems that have been addressed, with diversity there are problems with salaries, there are problems with getting providers where they're needed. All of this, in my opinion, comes down to the fact that we don't have a healthcare system in the United States. We have basically a healthcare free market, a free for all, where people where if you can get somebody to pay for something, you will do it. And so it's a totally messed up marketplace, and none of the things that we're discussing are going to be solvable, in my opinion, in the absence of some meaningful reform of our healthcare system. And so that brings me back to where I started, which is, what can this committee do? What should we be doing? And I think that the folks who were talking about sickle cell and the development program for APPs had the right target, is that we should be encouraging ways to really specifically identify what is missing in our newborn screening systems and follow-up, and then figuring out creative ways to address those specific needs. And I'm not sure that we're getting there, and I'm not sure what the mechanism for getting there is. I'd be curious what others have to say.
Georgianne Arnold?
Well, Sean stole a little bit of my thunder, but the SIMD has recently convened an ad hoc committee looking at workforce. And I participated in a few projects with Mark Corson for Rare New England on workforce recruitment. And one of the significant concerns of the candidates who come to the recruiting sessions is money. Not because they want to be rich doctors, because if you want to be rich today, you become a hedge fund manager, but because they have $200,000 in loans and they can't really go into one of the lowest paying medical specialties. And so with this group having a theoretical federal connection, I'm wondering, if you look at the NIH loan repayment program for people doing research, could newborn screening be added to that so that there's some loan repayment for people who work in the newborn screening field? Could there be a small grant program for recruitment seminars that we could go out and literally get pizza and Coke and go to medical students and college students and try to recruit them, educate them and recruit them into the field? So I would really like to see us perhaps utilize available resources to help ease the burden of going into this field. Because after talking to some college and med students fairly recently, it's real. The worry that they won't be able to afford a house or send their kids to college because they've gone into medical genetics is real.
Deborah Friedenberg.
Hi. So some of the questions I had have other people have raised, especially even in a state that appears to have a fair number of clinical geneticists, that doesn't really reflect what's happening across the state. There may be a large number of geneticists concentrated in one area of the state, while other areas who have significant population centers are underserved for genetics and may have no access to genetic services. And so there are large underserved areas where there may be a concentration of geneticists in one large urban area. And I think that's true for a lot of other states as well. Another issue was this transition issue from pediatrics to adult and medical homes. We dealt with a fair number of folks who have undergone that transition, and it's always a difficult period. But the feedback that we've gotten is that pediatric medical homes tend to have wraparound services, and when those patients wind up in adult medical homes, often they don't find those same wraparound services, and it's been a rather bumpy transitions as well for them. And then the third point that I just wanted to make is a lot of clinical geneticists are pediatric based, and if you're based in a children's hospital, you may have a hard age cutoff. That pediatric hospital may say you are not seeing anybody over 18 or over 21 or whatever it is. And Dr. Kwan has alluded to that. You know, it's a liability. We're not used to handling somebody with a heart attack or whatever. And I mean, I know I myself was pulled into my chair's office one day when I was treating an adult with Pompei's disease. That's why I was treating an adult. So when I was based in a children's hospital. So I think that that's a very real issue that's out there and that will continue to be out there in terms of geneticists who are based in pediatric centers are not viewed as being able to treat adults, even though most geneticists, clinical geneticists do treat adults. But I think that you need to recognize, depending on the setting where they are, that is also a barrier to care, to continuing care for long-term care as well. And in terms of recruitment and involvement of geneticists in newborn screening programs, it can be very difficult to integrate in a system that is not used to a specific category of genetic counselors, to integrate them into a state program. It's not impossible, but it is a large task. And I think almost everything else someone else has brought up. So thank you.
Thank you, Deb. Scott Schoen, you had your hand raised. If you want to say something, I'll give you the final word.
I think what Georgianne mentioned around sort of more incentive-based opportunities is where I think we need to be thinking, and I would expand it to the whole public health workforce, not just newborn screening. I think across the board, we've learned that there are challenges getting people to come into public health. The administration announced some huge opportunities yesterday to reinvest in newborn screening. And as we've discussed, I think what's important for those of us who have broader roles in public health beyond just the newborn screening system, as these opportunities come about because of the pandemic, that we make sure that all of the pieces that newborn screening touches are also incorporated in all these long-term infrastructure changes that we're making to the public health system. And again, I hate to sound like a broken record, but I keep coming back to system, and we all need to be aware of how integrated we are. And so when we make these adjustments, we're thinking about all the upstream and downstream activities and people and processes from where we stand, and look at that. So I appreciate Georgianne's comments around that. Because salaries, I didn't become a public health laboratory director to be wealthy, and I certainly wouldn't be as fulfilled if I were a hedge fund manager. And luckily I have a spouse who understands that. But anything we can do to help make these roles that we are so passionate about more attractive, and for our teams especially, who always solve every problem, is critical. So thanks for the opportunity, Dr. Powell.
Thank you. And thanks once again to all of our presenters for this session, certainly an area that many of us are extremely interested in and hope to have further discussions in the future about. Since we are running a bit over, I wanted to ask if the committee members have any new business or announcements. We don't have a lot of time for discussion. However, thinking about things for future discussions at future meetings will be helpful and welcome. Melissa Parisi.
Hi, this is Melissa Parisi from NIH. I just wanted to announce an upcoming 3-day workshop spread over 3 weeks, 3 Thursdays in June. And it is being sponsored by NIH and led by the National Center for Advancing NCATS. Now I cannot remember what NCATS stands for, but essentially the title of the workshop is Gene Targeted Therapies, Early Diagnosis and Equitable Delivery. And this will be Thursday, June 3rd, Thursday, June 10th, and Thursday, June 17th. And I don't know if there's anything that comes out of this. I'm happy to post the registration page for anyone who might be interested.
Thank you. Sean McCandless.
Thanks, Cindy. I had emailed Cindy and Mia after we had the public comment earlier this morning from the Everyday Life Foundation and from the Society for Gene and Cell Therapies. I really think that we need, I know that there's been a work group and there's we have been working on a plan for the evidence review and the evaluation of new disorders. But I think it feels to me like there's the points that those public statements made today was to warn us that there's a crisis coming in terms of new nominations and our ability to respond to them. And I think what we've seen from the MPS II process and the most recent processes is that we're going to be really challenged to address 10, 20, 40 new nominations over the next few years with our current system. So I just really hope that we could spend some time at our next meeting identifying specifically what the issues are that need to be addressed, and then really just trying to be creative about fixing the system or fine-tuning the system to make it more responsive and be able to turn things around faster. And I think this has to be the 800-pound gorilla in the room that this committee has to face, because it is one of our, if not the primary function of the committee, it seems to me, to make these, to advise the Secretary of HHS about these, about the rust. So I just want to put it out there that I think we really need to have more, we have to focus on that very soon.
Thank you, Sean. Anyone else? All right, our next meeting via webinar will be August 12th through 13th. And this meeting is now adjourned. Thank you all.
Thanks, Cindy. Thanks, Mia.
Thank you.
Thanks, Dr. Paul.
Thank you.